probably watch like most of them, and that is really, I really appreciate that. But my question is, I'm gonna take my exam in about 3 weeks, and I was trying to sign up for the bank because I basically your videos on YouTube are really nice. They have everything I needed anyway.
Mm-hmm.
But I don't know if the question bank is it like I want like to know more about it. Is it the questions basically like the question on the exam, the board exam, or I just want to know about it. Like, how do you sign up? Do you have like, if you sign up, how long do you have access to the questions?
That's a great question. You have access as long as you need it, usually 6 months. The course is called the PMHNP 30 Days to Walk to Success, meaning that you can do it in 3 weeks, you can do it in 2 weeks
Yeah.
if you have the time. The questions are part of the 30 Days PMHNP Walk to Success. So the if you want to just the questions, there are over 1,000 questions. You can practice with that. But I highly, highly recommend doing the course because you can do it the entire course. There is so much more in the course that's not on the YouTube. I'm not trying to say, I mean, many people have actually just done the YouTube and pass.
Yeah.
I have tons of people that have done the YouTube and they pass, and that's free and that's great. And everyone should, if you're not signing up, you should do that. But what I'll tell you is that the most high yield is really not the question bank, but the diagnostic test.
Okay.
Okay, the diagnostic test will absolutely tell you whether you are ready to test or not. And many people have told us that our diagnostic tests are very similar in the structure and the content that will be on the test. They will not be the same,
Okay.
obviously, but the content on it is very, very high yield. So if I were to pick between doing 1,000 questions, over 1,000 questions, the question bank or do the diagnostic test, I would pick the diagnostic test, honestly, because you are 3 weeks away. You're most likely not going to complete 1,000 questions, over 1,000 questions, maybe 1,400 questions. Two question banks we have there, one that's very high yield and one that's very broad, because we are trying to uh, get you what you need and then get you extra after that. So if you if you feel like, okay, I just want the diagnostic test, I think that's better, money better spent than the question bank in my view. But both are helpful and both come in a course already. So it's kind of like, okay, if you can get a nice discount and get both of them and get the lecture and get the crash course review, why only buy the diagnose test or the question bank? I mean,
So
it's everyone's choice. I just think that this is the most important test of your life. And if you're testing once, make sure that the preparation is on point, that you have never have to test it again. That's my opinion on it. So,
yeah, I know, but I've been preparing for like months, like over.
okay.
Um.
Yeah. So,
So okay, is that enough? Do you have an option to just take the diagnosis test?
yes.
I didn't see that,
Yes.
but
So if you go to our website, the www.npexamcoach,
mhm.
uh, I'm going to put here in the chat box, and then you can go to courses, and then there are a page where it says diagnostic test. Let me share that, and then you can just get the diagnostic test if that's what's most helpful to you. Uh, yeah, and that way you see whether whether you should be testing now or not. But I'll tell you that if you don't score 80, it's almost better for you to postpone your test. I'm not saying that you are not going to, but as I mentioned, it's you want to test it in a way that you will know that you will pass. And if you score 80% on it, you are good to go. Okay. And by the way, you can always email me and ask questions and things like that if you feel stuck. Okay.
Yeah.
Diagnostic test is here. So you just pick that, and you can either get one or two, or get a combination of one and two. And
Okay.
that is right here. If you get two of them, if you get one, 69. If you get two, is 99. So they're actually very similar. Okay. But these are very high yield content, and that should guide you what you are missing before the test date.
All right. Thank you.
Absolutely.
And everybody has
So
to pay for this test, Dr. Lupos.
say it again.
Everybody has to pay for the test.
No, no, unless if you are in the PMHNP Walk to Success, it's included in there, right?
Okay.
So the
Okay.
PMHNP Walk to Success, it comes with diagnostic test 1 and 2. It comes with a question bank. It comes with a complete reviews of modules with domains 1 through 5. It comes with a crash course review. It comes with the WhatsApp. Comes with everything. So basically, instead of saying, "Hey, buy this, buy that, buy this," why not just give it a huge package that makes a difference?
Okay.
Instead of piecing you guys for for everything. So I would just give it everything you need in one place, one location with PDFs, rather than like you should buy the LMR, and then you should buy the question bank, and you should buy. I I mean, I want you guys to pass. I'm not really trying to take every cent out of you, right? I get it. So that's the reason why we give everything on the 30 days PMHNP Walk to Success. Now, someone asked me, how long do I have it? You don't have 30 days. You have as long as you need, 6 months. I have people that are with us for a year. They initiated, they bought the package early and said, hey, can you give me more time? Yes. I'm not concerned about how long you're going to stay with us. I'm concerned about you passing. That is that I care. I don't care how long it takes for you. If you're still in school and you want to attend the classes, unlimited, as many classes as you want to attend, or as much support as you needed. Okay. So that is that. Okay, so we're about to get started with the first portion of the question bank. Is what I need. I never used the question bank. So Bina, send us an email, and then the question bank is located in a different website. We have our coursework where everything lives at, diagnostic tests, lectures, and we have a different website for the question bank. So you have, if you search your email, I promise you that you will see that we sent you a password and the link to your question bank. If you don't have that, email us at pmhnp@npexamcoach.com, and we'll make sure that you are set up for success. All right. So that being said, when you do modules 1, for example, then you stop, and then you should do question bank number 1. Then when you do module 2 videos, you should stop and you do all the question banks for module 2, and you keep going back and forth between both websites, between the learning and practice. Okay, so
Hey,
now
Dr.
we are,
Lupos.
yes, go ahead. Okay. Someone may have a question, but I can't hear. Okay, I agree that
I'm
would
saying,
be nice to have the
sorry.
rationales. Go ahead.
I said that I did that model 2. I went in to do the test,
Mm-hmm.
and I found out that a lot of the questions were from model 4. So I had to stop. It looks like model 2 questions were limited. I didn't go further because I had not really mastered model 4. So I had
Yeah.
to stop there. There were a lot of theoretical questions in model 2.
Yes.
So it made me stop right there, and then I had to do model 4. Then I'm planning to go back to model 2. So when you say if you do model 1, you go to the test question, model 2, you go to the, that's what I was expecting to see, but I realized that I could not do model 2 questions without model 4 actually mastering them. Even though I've done it before, but I had to go back and revise.
Yeah, so we're talking about two different things. One is question bank and one is diagnostic test, right?
No, I'm talking about
So
the question bank.
Okay. Yeah, it should match. It should match what you learned. Okay. But there's two types of question banks. So one is very specific to what you learned. Another one is very broad, things that you have never learned or we talked about. So that way you can use the strategies to kind of find the answer. Okay. Uh,
Okay.
yeah. So maybe
But
that you did the broad one and you were like, okay, I'm kind of feeling stuck here. That could be
but the
one of the
other ones were
reasons.
corresponding. The other models were corresponding. Just that model,
Mm.
2 questions had a lot of theoretical questions there.
Okay. Yeah, let me know if you feel stuck or if you feel that you didn't understand, send us an email. Okay. All right. All right. Marvin, you have a question before we get started?
It's Megan.
Mavens. Sorry, Mavens. Go ahead.
Um, Thank you. I was just wondering if for the crash review course, are there slides or something or PDFs or any way we can get this information?
Yeah, so it is part of the course and it comes
Mhm.
with PDF. Every module comes with a PDF and the videos. So you do this on your own and then you also attend live classes as many as you want. So under each video, like the first video for each class, there will be a PDF there for the entire module.
No, I mean for what we're doing right now. This
Yeah, I can send you the PDF for what we covered today. But we
okay,
are not going to, give you today is just a summary of the big event that's coming up on the 23rd and 24th. The
okay,
23rd and 24th, we are going over everything you need to know in 12 hours, 6 hours and 6 hours. So we're going to do a big event, and that is for the people that are enrolled in a class. So today is just a prime for what's coming up the next 2 weekends.
okay,
Okay.
got it. Thank you.
Yeah. Send me an email if you want if you want this information that we covered today, and I can send it to you. That's not a problem at all. I'll put my email here at the PMHNP at npexamcoach.com. It is in a chat box for the Google link. Okay. All right. So let's go ahead and cover the crash course review. It's, the initial portion of the crash course review. It's very, very important that you understand that if we are talking about it, it is because it's likely that you will see this on your test. Okay. So the crash course review is when you should be already very close to your test date. And for example, if we talk about Erickson, we are not going to talk about the 8 stages of development anymore. We're only going to cover maybe 3. They are the most high yield. Okay. If we give examples here, you should write down because they most likely will appear again on your test. And sometimes it might be 3, 4 questions in one slide. I'm not going to make one slide for each possible question. So things may be out of order, but it's assuming that you already have this content locked down. Okay. So if you have your mic on, kindly mute it so we can get started. Thank you. All right. So this is the part 1 of the crash course review. We're going to cover the thyroid, Depakote, Kava, Lamictal, Antipsychotics, Carbamazepine, Lithium, NMS, serotonin syndrome, antidepressants, psychiatric conditions that can increase suicidality, schizophrenia, MSE, mini mental status exam, clock drawing test, and the dopamine pathway. It is a lot, right? But this is not near 20% of the crash course review, right? So again, this is the most important test of your life. Make sure you pay attention. And if you today, since we're only doing a prime, just a bit of what the most important, please ask question. I'm okay with stopping and answering your question any moment. Okay. So if you look at the purple book, it will say that the thyroid stimulating hormone, the TSH value is 0.5 to 10. That is incorrect, right? So the correct value, the first thing you need to know is 0.5 to 5. You need to know this range. Few labs you need to know, and that is one you need to know. So hyper and hyperthyroidism, why does it matter in psychiatry? Well, because hyperthyroidism looks like mania, anxiety, right? I had someone that was passing out on formation. In a military formation is someone that, you know, we got to meet and stay in line, and it's in the hot sun, and this person's passing out all the time, and everybody was working this person up for anxiety until I got her thyroid stimulating hormone T4 and T3, and I was like, wait a minute, this girl actually has hyperthyroidism. She is sensitive to to warm weather, right? To the heat, not cold, heat, hyper. So sometimes those folks with anxiety, lots of anxiety, it could be because of the thyroid gland is accelerated, right? It's hyperthyroidism. And many folks with mania or mania acting like mania, it could be because of the hyperthyroidism. So it's good to check. On the other hand, hyperthyroidism looks just like blah, depressed, cold sensitivity, and slow, and constipation, right? That is hypothyroidism. On your test, you have to be very, very careful because this will be a hard question. Just like the dopamine pathways can be a hard question. Remember when they say that for the questions to be correct, the entire answer needs to be correct. So watch out when you're doing TSH, hyperthyroidism. Watch out when you're doing the dopamine pathways for two sentences connected by and, that the entire answer needs to be correct. So when you have a question about TSH, look at your answer, your stem of the question, and ask yourself, what is the TSH? Is it high or low? Start with that. Okay. Then look at the T3, T4. When the T3, T4 are high, right? And the TSH is low, then you have a case of hyperthyroidism. So what is a low TSH? One that's less than 0.5. So first thing, you look at the question, ask yourself, is the TSH high or low? Less than 0.5, it is a low. Is the T3, T4 high or low? High. So you have an inverse relationship. If the TSH is going down, T3, T4 is going up, you have hyperthyroidism. On the other hand, when the T3, T4 are low, and your TSH is high, meaning more than 5, then you have hypothyroidism, meaning there are cold intolerance, lethargic, gaining weight, decreased libido. For example, TSH is 6, T3, T4 is low. Someone had a question, please ask.
My question is there a way the TSH and T3, T4 on the low side at the same time?
What do you mean by that?
You said the TSH is 0.5 to 5, right?
Yes.
And then when the TSH is high, and at the same time the T3 and the T4 is high, is it possible that way?
Oh, it is possible, but it wouldn't necessarily mean a clinical picture for hypo or hyperthyroidism, but it is possible.
Okay.
Okay.
So in case of that, what will you do?
Say it again.
in case of situations like that, what will happen?
Well, then you have to discern other tests to see if this is a true hypo or hyperthyroidism. But for the test, there will not be complicated like that.
Okay.
It will not be complicated. There will be an inverse relationship.
Okay.
And then you look, first thing you look at the TSH. If it's low, then you look at the T4, T334 is high, then you know it's hyper.
Now, what is the actual level of the T334? Because sometimes I get in the book, it's different.
Right. So it's on the test, most likely they will say whether it's high or low for you.
Now,
Okay.
what is the normal level for T334?
So T3, 3, 4, and T4 levels for the thyroid. Anybody knows this answer?
Isn't it 0.82? I don't know.
Yeah.
Is
Yeah. So it's
2.8.
right. So it really depends whether you're looking at the T4 itself. So the T4 itself, right? Whether it's a free or total. So if you look at the free, which is the thyroxine T4, is 0.8 to 2.4. But again,
Yeah.
it depends on your lab, right?
Yeah.
For example, yesterday I asked someone to get a testosterone level, and I was expecting to be less than 300, like scientifically, but their lab results, in order to be low, it would choose 64, which was kind of weird, but that's what their lab is using as characterizing as low. So I don't want to complicate this, but T4, the free thyroxine, 0.8 to 2.4. If you
I think it
use
was
the total, it will be 4.5 to 12.5. And then we can do the same thing. The T3, it will be 2.3 to 4.2. But again, it's not that important, okay? For the test, you can just remember T4, 0.8 to 2.4 as the baseline, but even that's not important, okay? All right, so let's keep on going. If you have your mic, please mute it. So when you are doing this question, you have to go each answer carefully and write it down. Is this T3 TSH high or low? T334, is it going in opposite direction? What is it? Because it can be very complicated. Remember, for the question to be a correct answer, the whole question needs to be correct. Okay? So if you don't know hypo and hyperthyroidism, here alone, we learned that hyper can be seems like mania or anxiety. Hypo, it can means like can be seen as depression. We learn the symptoms of hyper, heat sensitivity, anxiety, agitation, irritability, tachycardia, losing weight. And we learn the symptoms of hypo, cold tolerance, lethargic, gaining weight, decreased libido, for example. And we know the levels of TSH. Okay? So very important that you go for each answer and find out whether it is whether it's high or low, and then you cross each one of those answers. Okay, very careful. We have to do very careful work here. Now, do you need to know psychopharmacology in detail? No. You need to know all the gold standard FDA warnings. When you hear Depakote, first thing that comes to mind is, what are the two black box warning? The two black box warning for Depakote is liver toxicity and pancreatitis. And by the way, you need to know what liver toxicity looks like and what pancreatitis looks like. Okay? So you know now that liver toxicity and pancreatitis are black box warning associated with Depakote. Okay, so interventions for liver toxicity include discontinuing the offending agent and then performing LFT. You always stop the offending agent before you collect labs, right? You don't have to collect labs, get the results, and then you stop the medication. Now, yesterday, we had actually a very interesting question on the diagnostic test, and I think was, I forgot her name. I can't pronounce her name. She had a great question. It was about lithium toxicity. And she thought that the right answer would be to discontinue the medication, which is the right answer. However, someone is in ED. You have control of their meds. Telling them to discontinue the medication is less helpful than getting the vital signs and EKG. Do you see the difference here? Now, if someone calls you and saying, hey, I have these symptoms, your immediate action is to discontinue the medication. Pay attention on your settings, okay? Because it could be the difference between the right answer and the wrong answer. Now, back to Depakote. What are the two black box warning? Liver toxicity, pancreatitis. What do you do for any medication when you find symptoms in the description of the question? You discontinue the medication. At AST, ALT, you can do, I memorized just the ALT, which is 5 to 35. I add 5 to it. Now I have AST, 5 to 40. What are the therapeutic range for Depakote? You want to be between 50 and 125. If levels start to go higher than 150, what do you see? Disorientation, lethargic, sometimes respiratory depression, nausea, vomiting, sometimes diarrhea. So intervention involves discontinuing the agent and conducting a LFT and high yield ammonia level. Okay, ammonia level. Liver toxicity, what does it look like? Remember when I said you need to know what they look like? Because oftentimes they'll have abdominal pain. Where? You can touch it in the right upper quadrant of your belly, or the patient's belly. They'll have reddish urine, the yellowing of the skin and the white of the eye, and they'll feel fatigue. So you need to know the symptoms of liver toxicity. You need to know the symptoms of pancreatitis. Think of it as oily stools. I know, very graphic, but you won't forget anymore. Oily stool, right? And they'll have abdominal pain, radiating to the back, fever, rapid pulse, nausea, vomiting, oily stool. So, if it's your patient's taking pancreatitis, I mean, it's taking Depakote, not taking pancreatitis, right? And call you and says, hey, Dr. X, Y, and Z, I've been taking my medication as prescribed, but lately I felt this abdominal pain radiating to the back with fever, mild fever, just 101, and I've been feeling nauseating lately. And by the way, having this oily stool. Then your action is to tell the patient to stop taking the medication immediately and go to the ED. It's not, oh, let's set up an appointment and meet with you in the next few days. No, you recognize that it is pancreatitis and the person needs immediate care, needs to go to the ED. Okay? All right. Kava. What are the important things about Kava? If you notice our course, we do not add a lot of herbs. Well, it could be over 100 herbs that could be on your test, right? But if we include everything, then nothing's important. So we include what you're likely to see. And that is what the crash course review is all about. You are likely to see Kava. Okay? What is that? It's a medication used to treat anxiety, a herb to treat anxiety, stress, and insomnia, right? However, it can also damage what? Liver. Therefore, your priority test is to conduct a liver function test, ALT-AST. What you should never give together with Kava. You should never give benzodiazepines, right? Think about it. Kava makes one go to sleep. Benzo does the same thing. So you will potentiate your benzodiazepine. They do not go together. They will cause drowsiness. And as you imagine, if someone's going to give anesthesia, you probably want to stop Kava before surgeries. Okay, so a few things about Kava. What is the reason why people take it? Anxiety, stress, and insomnia. What are the labs you need to be worried about? We want to be worried about liver. So you want a liver function test. What we do not mix Kava with? Benzodiazepine, and always stop Kava before surgery because it could potentiate the anesthesia medication. Now, Lamictal. When you hear Lamictal, be concerned about Stevens-Johnson syndrome. In practice, has anyone prescribed Lamictal before? Nobody? All right, I can't see it. If you have, Melissa, do you remember how you prescribed Lamictal? If you don't, that's okay. We can. 25, great answer. And how long do you take 25? Very low, very good answer. 25, first 2 weeks, perfect. Absolutely, great answer. So you start 25 for 2 weeks, then you increase to 50 for 2 weeks, and then you increase to 100 for 2 weeks. Or you don't have to be on 200 until you achieve the results that you want. Now, here's the question. If you have a patient that is taking Lamictal and they develop a rash, but the rash goes away, what is the most likely action that you should do?
I think you continue the Lamictal.
Perfect. You continue the Lamictal. Do not fall for the trap of discontinuing because of rash. Rashes that are Stevens-Johnson syndrome, they do not stop. They are violent. They are brutal. They're actually scary. It's an emergency, right? So I hear patients say, I had a patient last week that had rashes, bilateral rashes. I said, okay, come to the office so I can examine. It was working out rashes, right? Like under the armpit. There is no need for me to stop the stop Lamictal, right? Your severe rashes. So when you hear Lamictal, think of Stevens-Johnson syndrome, a possible severe rash. And they look like fever, body aches, peeling of the skin, facial and tongue swelling. If you have not seen Stevens-Johnson syndrome, Google it, please, because you will never forget. Okay? Now, we talked about antipsychotics. They are cause least weight gaining. Now, if we say which mood stabilizer causes the least weight gaining, Lamictal is the answer. Pick this medication when the patient is at risk for metabolic syndrome and needs a mood stabilizer, Lamictal. Okay. So we cover Lamictal, we cover Stevens-Johnson syndrome, signs and symptoms. We cover that it is the least weight gaining mood stabilizer, and when to pick this answer for Lamictal. Okay. Now, if you think that well, we'll go back to Stevens-Johnson syndrome one in a little bit. So let's cover antipsychotics, right? So if Lamictal is the least weight gaining antipsychotics, you can pick at least 3. There are more than 3, at least 5 or 6. There are least weight gaining antipsychotics. Think of it as ziprasidone, aripiprazole, and Latuda. Some people might call it Zal. Okay, make it easy. Ziprasidone, aripiprazole, and Latuda. What is about Latuda and ziprasidone that's kind of different than other medications?
Eat them with food. Yes.
Perfect. They need it with food, right? Preferably anywhere between 350 calories to 500 calories. So, which is kind of weird, isn't it? But remember, Latuda and ziprasidone, when ingested with food, it increases its bioavailability. Okay. Now, what is the number one symptoms that you will see when prescribing antipsychotics, specifically second generation? Number one symptoms that you see is
Metabolic.
sure metabolic. Let me rephrase. From the metabolic symptoms, what you would see first is
Weight gain.
sure,
obesity.
yeah, hip to waist ratio increase. Okay, that is important. I know all the answers you provided is correct, but the number one is the increase. Yeah, so sometimes called just a hip increase in circumference, hip to waist circumference ratio. Now, when do we talk about antipsychotics, first generation versus second generation? First generation, it has the potential for EPS. Second generation has the potential for what?
Metabolic.
Metabolic syndrome.
Metabolic syndrome, right? So what happened is that when the antipsychotics blocks the dopamine, remember that the problem is too much dopamine in schizophrenia, for example, and we want to block that. On the first generation, we block that at 80 percentile. And that works pretty well. It will almost certainly decrease the schizophrenia signs and symptoms, positive signs and symptoms at least. But it will come with the side effect of possible extrapyramidal side effect. So what they did is, well, let's make a medication that doesn't cover 80%. It will cover 60%. And now we don't have as much EPS, but it comes with a little extra problem, which is the weight gain. In order to call metabolic syndrome, you got to have 2 of those 5. It's more than 5. Weight gain, metabolic, BMI, hip to waist ratio, glucose, and lipid. When you have 2 of them, you can call it metabolic syndrome. Okay, so now when you have a patient that is stable on, let's say, Geodon or Olizapine, whatever, doesn't matter. It's stable, but the patient is kind of gaining weight. What do you do first?
Nutrition and exercise.
Yes, do not switch to ziprasidone. Do not switch to Abilify. do not switch to Latuda. Your first action, remember priority, your first action is to exercise counseling, exercise and counseling the patient about nutrition, seeing if you can manage without switching the medication. If that's not possible, then if that has been unsuccessful, then you pick one of the ZALs. And if you ask, out of those antipsychotics, which one is the least sedating, aripiprazole or Abilify would be your answer. Okay? So, for example, if the patient is taking Seroquel, your initial action would be to recommend exercise, nutrition, counseling, and then one of the ZAL's medications, ziprasidone, aripiprazole, and Latuda. Okay? So do not destabilize your patient because of a weight gain. Try other measures before you switch your medication. Remember when we talked about Lamictal, and we said Lamictal is almost akin to Stevens-Jones syndrome. It's not true, but for the test, right? So is the Lamictal only medication that could cause Stevens-Jones syndrome? No, no, no. Carbamazepine could cause Stevens-Jones syndrome. So the question is, when you have a question that you have Lamictal and Carbamazepine as the answers, which one do you pick? Right? It depends on what. If the question it's about Stevens-Jones syndrome and it's referring to patients of Asian population, then the answer will be Carbamazepine. If it's not mentioned Asian population, then the answer will be Lamictal. Why? Well, because Carbamazepine is known to increase the incidence of Stevens-Jones syndrome to those of Asian population. So what you want to screen for is this HLA-B 1502. I just call HLAB 1502, like the room number 1502. So I remember HLAB 1502 before prescribing Carbamazepine to the Asian population. Okay? So remember, what are the two black box warning for Depakote, right? Now, you want to know the two black box warning for Carbamazepine. Agranulocytosis and aplastic anemia. So 2 for Depakote and 2 for Carbamazepine. Agranulocytosis, which is the decrease in white blood count, and aplastic anemia, which is bleeding of the gum, pallor, fatigue, headache, nosebleed, rash, skin rash, shortness of breath. Okay, so Carbamazepine is not only involved with Stevens-Jones syndrome. It has another medication that also shares commonality, which is agranulocytosis. So Carbamazepine gotta be concerned with the Stevens-Jones syndrome, but agranulocytosis, and so is Clozaril. Clozaril and Carbamazepine both could cause agranulocytosis. So, question: patient is on Carbamazepine. ANC is 1200. The patient is doing okay and reports feeling great. However, the patient reports a sore throat. Which of the following would be your priority next? Let's say white blood count is 5,000, right? ANC 1200. So continue Carbamazepine, discontinue Carbamazepine, switch to Clozaril, or continue to monitor the patient.
Discontinue.
Discontinue, right? Despite of the ANC. Honestly, is anyone that thought about not discontinuing this medication? Tell me now, because it's important. Okay. So you discontinue clozaril or carbamazepine at any signs of infection. Oh, but you only said sore throat. Oh, the question only said a minor fever. You discontinue the medication. What else do you discontinue the medication? When the ANC is less than 1,000. Okay, whether or not the patient is showing any signs or symptoms of infection. Okay, so discontinue carbamazepine or clozaril when ANC is less than 1,000. WBC, some providers may do less than 3,000, or any signs of infection, regardless of ANC, WBC numbers. How can you remember aplastic anemia, agranulocytosis, and Asian population? Look at carbamazepine, has 3 A's in it. One is for agranulocytosis, one's for aplastic anemia, and one is for the Asian population. You need to know what aplastic anemia signs and symptoms look like. Think of brushing your teeth and bleeding all over your mouth, right? That will give you aplastic anemia. Try to always make it exaggerated, unrealistic images that will stick with you and you will remember, okay? And sometimes they are inappropriate. Don't tell anybody, just keep it to yourself as long as you can remember, okay? All right, so we covered earlier a lab that we needed to know, which was the TSH. Now we're going to cover another lab that we definitely need to know, which is lithium. When to stop, when to continue, what to do is if it's above 1.2, 1.3. Well, let's cover all that. So start off by saying 0.6 to 1.2 is normal. This is where we want my lithium levels to be. Okay. So if lithium is the gold standard for bipolar, and there is anti-suicidal effects for those patients with bipolar, and decrease the amount of suicidality, why don't I start lithium for every patient that comes to the inpatient unit? Why?
It's a neuroprotective.
Sure, it's neuroprotective, but why I would not start lithium for any patient that has suicidality and is a bipolar patient right away?
Because it takes time for
Perfect.
lithium.
Excellent. So yeah, that is a clinical question that you need to know, and possibly for your test too. So think of this as a very narrow therapeutic window, 0.6 to 1.2. Okay, you miss this, you are screwed. Okay, or your patient is. So it takes time and takes labs, and that you don't want to keep your goal for inpatient is acute stabilization, discharge the patient safely to outpatient treatment facilities so they can manage. You do not want to wait lithium level to be appropriate and stable for 2 weeks and keep your patient for that long. Okay, point made. Now, know that is neuroprotective medication of choice for those with bipolar, with mania. It can protect the nerves. So that's first information. If you have your mic on, kindly mute it. It is the gold standard treatment of choice for bipolar, and it has anti-suicidal effects. What other medication has anti-suicidal effect for schizophrenia?
Clozaril.
Clozaril. So these two medications you need to know. anti-suicidal effect for bipolar. Lithium, anti-suicidal effect for schizophrenia. Clozaril. Which psychiatric condition has the highest suicidal rate?
Schizophrenia.
Schizophrenia. You need to know. Which, I'll call race or ethnicity. Call ethnicity, I guess. Which ethnicity has the highest suicidal rate?
Native American.
Native American.
Native
Black.
Americans, okay? Great. Native Americans. So psychiatric condition, schizophrenia. Ethnicity, Native American. Which psychiatric condition has the highest incident of homicidal acts?
Antisocial.
Antisocial, okay? Now back to lithium. 0.6 to 1.2. Above 1.5 is toxicity. What if it is 1.3? What do I do? You monitor the patient.
Observe.
Yeah. Now the patient develops symptoms, you stop the medication. No symptoms, you continue. Okay? So remember, it's a narrow therapeutic window, 0.6 to 1.2. Above 1.5, we're in trouble. So if we're in trouble, what do we need to do? We need to collect labs. So what labs do we collect? TSH. What is the value of a TSH? 0.5 to 5. What does it cause? Hypo or hyperthyroidism?
Hypo.
Hypo. Great answer. Hypo, right? And why do I care about BUN and creatinine? What's about it? What does it tell me?
Acid is excreting the lithium.
Okay, so it tells me about the kidney function,
Function.
but
yes.
also it tells me about dehydration status, right? I can make some assumption of that. And dehydration is high yield for lithium. We'll cover that in a minute. So I want my TSH, I want my BUN creatinine. These are brothers and sisters, they come together, right? And I want my UA. And if I see protein on my UA and there's a large amount, like a +4, what does it mean? Do I stop the medication or no?
You stop the medication.
Stop it.
Okay, great answer, but not the answer that I was expecting. Yes, you are concerned. You are concerned, but you are going to keep your medication and monitor closely. You do not need to stop the medication if it's protein +4. Okay, but it is of a concern. You need to monitor closely. Okay. High yield for all questions, for all answers, and I'm being a blank statement here. Anytime you see HCG as the answer, most likely that is the answer. I don't even care what question they're asking. Unless if they're gonna totally put a HCG, I don't know, they're talking about therapies and put HCG, right? That doesn't make sense. But HCG is all about safety. Is almost always, if it comes up, is because we need to monitor for pregnancy and anything along those lines. So if you were stuck in a question, you just don't know the answer, and HCG shows up and it's about the medication, that could easily be the right answer, okay? Because about safety. So when it comes to age, right? When it comes to age and what age you need to monitor for the test, for HCG is 12 to 50.
To 50. Mm-hmm.
Okay? And you want to monitor because if the patient becomes pregnant, then they could develop abstinence abnormality, which is a heart defect.
Mm-hmm.
Okay? So, for example, here, knowing this, that it could cause a heart defect, and your patient comes to you, and this is a 35 years old male, and then you put your microscope, you see this murmur, a grade 2.5 systolic murmur. And then one of the questions you could ask is, and this is a bipolar patient, right? And then you could ask, has your mother taken lithium when she was pregnant with you? This is akin to say you understand that this medication causes heart issues. Okay, not necessarily. They will unlikely ask a direct question for you to say, which of the following they will ask you instead a level below or above. By knowing that lithium causes heart level, what kind of questions would you ask this patient, or what would you assess? Okay, so we mentioned that the lithium could cause symptoms, side effects, and one of them is hypothyroidism, right? Fine hand tremors. If you hear the question that says coarse hand tremors, that is toxicity. Before we actually keep on moving, I'm super sorry because I didn't say, I didn't see the hands raised. Can we have a Cooper? Do you have a question there, my dear?
Yes, sir. Doctor, I have a question. Like, I didn't get actually like what was the relationship with the lithium with the protein excretion in the urine, because I did the diagnosis test and obviously there is no explanation over there. So I didn't get that point, like why we have to be monitor, like why we have to be concerned about the protein, because over there is a question. Over there is a BUN also like a more than
Right.
20s, around like 30, and the urine protein is the +4. So correct answer was like I was expecting is a BUN, because we always go like whatever is higher, like increasing value. But that protein level also increased, but I never have any idea like what was the
Right.
exact relationship with the liver and the protein, you
Okay.
know. So can you
So,
please, yeah.
Yeah, absolutely. So the question on the diagnostic test, it just had a slightly elevated BUN and creatinine, very slightly,
Mhm.
and had urine protein +4, right?
Yes. Mhm.
So why do I care? Well, because it could indicate kidney dysfunction, which if the kidney is malfunctioning, it could rapidly increase the lithium's level.
Mhm.
So out of those symptoms, you would be more concerned about the +4. But
Okay.
in itself alone, it's
Mhm.
not necessarily you must stop. It's necessary that you follow carefully.
Perfect. Mhm.
Okay. And the reason why we don't give rationales is because you have the PDFs, and we want you guys to go back in a PDF and look
No,
for
no,
the
definitely. But that's the test I have to be take before I start my study, you know.
no,
So
absolutely.
by the time is the, you know, we are already studying for the lithium. So I was like, let me just clarify myself
No,
in
yeah.
a, you know. Yeah. Thank you so much, doctor. I appreciate that.
If not, Mavis, if you do have a question, please ask. Otherwise, we'll keep on going.
Yes, Mavis. I wanted to go back. It was earlier regarding the liver function test. Are we only looking at the AST and ALT? Are we looking at the bilirubin and the other liver exam?
Yes, but that's we
Test.
could look at bilirubin. We could do that. However, for the test, is most likely ALT, AST.
The AST.
Yeah.
Okay.
So it will, you know, think of this as the basics you need to practice, right? The basics, they are not going to be like super in depth on critical levels that you would see in the ICU, for example, right? So they only want the basics to start off. Okay.
Okay. And then the other question I had with regards to pregnancy, you said that the age that we're going to monitor and watch for is ages 12 through 50. Is that correct?
Yes, because scientifically speaking, one could get pregnant at 12 and 50. Not the norm, right? But it is. So let's talk about that for a second because something came to mind. Okay. If a 16 years old girl doesn't have her period, she's 16. Is this normal or abnormal?
She never had it at,
It
are you
could
saying
be
she
Yeah.
never had it at all?
She never
abnormal.
had it at all.
Abnormal.
It's not abnormal. Some people
Okay.
start
I would
early, some
say,
start late.
it could be normal, I think. I don't
Okay,
know.
it could be normal. Yes, it could be
Yeah.
normal. So that is a clear example where 70% of you guys would get it wrong because maybe it wasn't your norm and you
Right.
using yourself as the parameter to what's normal and abnormal. So that is a great one. So second one, talking about the same thing, the female that having bone spurts on her legs, right? So the kind of leg pain. Is this necessarily, and you don't have an injury, is this necessarily normal or abnormal or expected for their growth?
Expected.
Normal. Expected,
Normal.
right? Right?
Yes.
So what is your job? Is to educate the patient and the family. The same thing. 14 years old boy with titties bigger than his sister. Is this normal or abnormal?
Normal.
Normal. Okay. So these three examples are high yield. Okay. It means we don't have, means until, you know, if they get older and they're having those symptoms, then we do more intense diagnosis and treatment and labs and things and, you know, studies. But these are normal. It just doesn't mean that we went through those stages, but be careful with normals. They're in disguise as almost abnormal. Okay. All right. So back to lithium. What can it cause? Hypothyroidism. If you hear fine hand tremors, it's normal. I mean, not normal, is side effect. If you see curse hand tremors, then it is
Toxicity.
toxicity. Fine hand tremors, you can't see. Patient will tell you, but you can't see because it's so fine.
You
Curse,
said
you can
what
see.
would be toxicity? I'm sorry. What did you say that would be?
Curse hand tremors. Okay,
You
that
said
would be considered.
curves?
Yes.
Course. Please, can you spell the course,
Oh,
doctor?
course trip.
Because my camera is kind of.
Accent.
Here we go. Somebody spelled
Course.
for me. Thank you for that.
I cannot see the camera.
Uh,
It's coarse hand
Yes.
tremors. Coarse.
Course hand tremors equals toxicity, lithium.
all right. Yeah, you can't. Okay, no worries. Okay, so that is the first thing. Now, note that lithium can cause a T wave inversion. Lithium can cause a T wave inversion, right? So this is why it's important to get here you go, I'm back. In EKG. But it can also cause polydipsia, polyuria, and signs of diabetes insipidus. right? It can also increase your white blood count, which is leukocytosis. And we talked about symptoms during pregnancy, especially during the first trimester, right? First 3 months is the most important because that's when the heart is formed. Okay, so what lithium toxicity looks like? Severe. All right, again, blank statement. Anytime you hear severe, extreme, for any medication symptoms, it is toxicity. Nothing should be extreme, severe headaches, severe diarrhea, severe ataxia, severe whatever, vomiting. That is not normal for any medication. It almost a blank statement. It's anytime you know toxicity on a type when it goes on to say severe anything. Okay, so just so if you don't know the symptoms and you're like it says severe and you're stuck, most likely this is a toxicity level for the medication. And your action is to stop the medication. Now it could cause confusion, drowsiness, curves and tremors, gait abnormality, ataxia, right? The walk. Your priority is to discontinue lithium first and check lithium level. Do you check lithium level first and discontinue? No. You stop the medication, then collect labs. Which labs? TSH, BUN, creatinine, UA, and obviously always you want a HCG for ages 12 to 50. Okay. So lithium levels 0.6 to 12. Lithium increases its level anytime you have kidney, could potentially, with kidney disease. So if the person has an acute chronic or acute kidney disease or chronic kidney disease, the lithium level could be affected. Any drugs that is bypassed by the kidney or influences the kidney's function, it could potentially increase lithium level. Of note, ibuprofen, NSAIDs, it in theory could double of the lithium level. So do you prescribe lithium and NSAIDs? No, in theory, right? In practice we do. But in theory, no. For the test, no. Chlorothiazides, any thiazides medication, any blood pressure medication, it could increase lithium levels. ACE inhibitors, two things to remember. One, could increase lithium levels, and two, what is the other reason why we could, now not we, but in general, prescribe ACE inhibitors? For those with cardiac failure, that is high yield. Lisinopril, oh, it's a blood pressure medication. Yes, so then it could affect the kidney, which could affect the lithium. Very high yield. Dehydration. Dehydration can increase lithium levels, right? So that often comes in task format is worker, construction worker working in Florida, sun, heat, outside, building houses. They are at risk for dehydration, right? And therefore, they take lithium. Your goal, action, is to provide education about hydration, right? Now, sodium imbalance can also increase lithium levels in two ways, whether it's hyper or hyponatremia. Funny, right? So, but it can lead to an increased level by decreasing the renal clearance. And this is how, this is not super high yield, but I like to explain things sometimes. So how can it be high or low affect the kidney? Well, let's say it's high, right? You have a lot of sodium. So your lithium is primarily excreted from the body through the kidney. In hypernatremia, the body what will do is, hey, let me keep all the water, and because I have a lot of salt, so I'm going to stop peeing, stop urination, retain the water so that the salt can be diluted, right? So it decreased the urine output, which also means less lithium is excreted, which leads to an accumulation in blood levels. You guys get it? How high sodium could cause increase of lithium, because the body will say, no more pee, I'll keep all the water, I'll keep all the lithium, and now I have increased lithium level. So how would that work for hyponatremia? In the case of hyponatremia, low sodium, the body tries to dilute the blood by excreting water. So, there is a lot of water, sodium is small, let me take the water out and keep the sodium. This leads to an increase in urine output, which also lithium is reabsorption in the kidney alongside the water as a compensatory mechanism to prevent excessive lithium loss. So this will happen is it will increase the lithium absorption leads to less lithium being excreted and higher lithium levels. What do you care? Only hypo or hypernatremia could increase lithium levels. But if you care to understand, here's the rationale. All right. Someone has a hot mic. Please mute yourself so we can have a better sound for those that watch this later. Thank you. NMS. What causes NMS to begin with?
Let me just clarify again. So you're saying that hyponatremia and hypernatremia, that's the only electrolyte that will keep lithium levels high?
No, absolutely didn't say that, but I said that that is the main electrolytes. But other two could cause a little bit of a problems, like potassium could cause problems specifically because of the heart, and lithium could cause T inversion, but specifically sodium is high yield for lithium. Okay.
Yeah, I understand what you were saying, but I was just trying to clarify if both hypernatremia and also hyponatremia can cause toxicity. That's what I wanted to find out.
Yes, absolutely.
Okay.
Both can cause toxicity.
So in that context too, how does hypokalemia affects the kidney and lithium levels?
Yeah, we could discuss that, but we'll discuss that at the end. Just hold your question because it's not necessarily super high yield, and I want to cover what's high yield for the test. But we can definitely go on calcium level and how it affects the kidney and how it affects lithium. Just hold that question. Let's go in detail that at the end of the course. Okay.
Okay.
But please remind me, and we'll go over that. So, question is, when you hear NMS, first question you ask is how we got there. What causes?
Antipsychotic.
Okay, so that's a great answer. So if it's not because of antipsychotic, it's most likely not NMS. Questions often will compare NMS with what other condition?
Serotonin syndrome.
Serotonin syndrome. So you got to discern NMS to the left, serotonin syndrome to the right. You got to really know this because you get tons of questions on this. So first, NMS caused by antipsychotic. Second, what is different about NMS that you don't see on serotonin syndrome? Well, let's start with what's really different. Is muscle extreme rigidity. Remember, I even said it extreme, right? Anything that has extreme is likely to be a side effect. It's sometimes called lead pipe rigidity. Mutism, you don't see on serotonin syndrome. elevated CPKs because your muscles are breaking down, and then that's going to show up on your CPK levels. And because your muscles going to break down, now you have excess molecules, and it will cause myoglobinuria, right? Which you will see as Coca-Cola like urine, right? And then you have white blood counts. You're starting to get a fever, elevated white blood count. You may get it. That's like the body say, hey, I'm being attacked. Let me start producing more white blood count. And then you're going to have a kidney function test will be elevated, AST, ALT, right? So NMS, you need to know CPK, myoglobinuria, white blood count, and LFTs are elevated. Symptoms, muscle-like pipe rigidity and mutism. And what do you do? First, stop the offending agent. Now you're going to call two medications, the Bro and the Dan. So, what caused NMS? Was it because of antipsychotics? What's another name for antipsychotics? What's it called again? What can you call antipsychotics if you don't call antipsychotics and you don't call first or second generation?
Psychotropic.
Dopamine.
Yes, I want to hear that. Dopamine antagonistic. So the problem was a dopamine antagonistic. So how would you solve a problem for a dopamine antagonist? You got to call a dopamine agonistic, and that is important. Because if the question asks you, which of the following medications would you give for this patient that will never tell you this is NMS, will give you the symptoms, but will never tell you this is NMS, it's your job to know. And the answer is dantrolene or bromocriptine, but your question will say dopamine agonistic, then you call the bromocriptine. Dopamine agonist. Think about it. It was caused because a dopamine antagonistic, you want to fix the problem, you call a dopamine agonistic, which is bromocriptine. You need to know the difference between bromocriptine and dantrolene. Dantrolene sounds like a flower. So it's relaxed. You know, to me, I think of dantrolene as a flower. I don't know why. It's just relaxed. So it's for muscle rigidity, you give dantrolene. If the question asks for dopamine agonistic, you give it bromocriptine. You need to know this. Dopamine, bromocriptine, and dantrolene. When would you give one or the other? Because the question is likely to have dopamine, bromocriptine, dantrolene, you're like, oh my God, I don't know which one. Okay? So if NMS, you have mutism, you have lead pipe rigidity, you have CPK, white blood count, myoglobinuria, and LFTs are elevated, then serotonin syndrome you have first caused by serotonin, antidepressants, TCAs, MAOIs, SSRIs. You have hyperflexia. So the reflex are exaggerated. And then you have seizure-like movements called clonic jerk movements. What do? First thing, it's stop the offending agent, and now you call cyproheptadine. Again, what is the cause of serotonin syndrome? Was a serotonergic blockade, right? So you want a agonistic cryptoheptadine here. What is the question that you have? Someone have a question there? I heard a little blink. Pro. You have a question? If you do, unmute yourself. If
Actually,
no,
like actually, I'm not sure it's just my end, but I cannot able to raise the hand, and your voice is like kind of be echo since we are being on NMS, and I wanted to be raise my hand, but it's not. And
yeah, I
like,
can see your hand. I can see your hand raised, but what happened is that I'm looking at the different screen for the presentation. So oftentimes I don't see. I hear the noise, but I don't see who raised your hand. But do you have a question?
No,
No.
because we
No.
cannot hear properly. That's only the reason.
Okay.
Thank you.
Is anybody else not able to hear the sound well? Or
No, we hear fine.
It's okay.
okay. All right.
We can
So-
hear fine.
Okay, great. Thanks for the feedback. So first thing to know is that NMS was caused by antipsychotics. Second is serotonin was caused by antidepressant. Then we talked about the symptoms of NMS. Now, what is particular to serotonin syndrome is hyperflexia, exaggerated reflex, myoclonic jerks, seizure-like movement, right? Everything else, it looks like NMS. Hyperthermia, tachycardia, diaphoresis, excessive sweating, and altered mental status, confusion. Who do we call for serotonin syndrome? Cryptoheptadine. Okay, cryptoheptadine. So please know in detail the difference between NMS and serotonin syndrome. Now, antidepressants. Well, remember, Depakote, what are the two black box warnings? Carbamazepine, what are the two black box warnings? Antidepressant, all of them, black box warning, can increase suicidality or self-harm in children, adolescents, and younger adults. So what is your priority? Assess for harm and youth adults. So your priority is to assess if they are younger than 23 to disclose the possibility of suicidality. Okay? So teens and children have fewer experimental studies investigating the efficiency of antidepressants in children and adolescents when compared to adults with depression. They have a reduced placebo response. Well, not true. Not a true statement, okay? So in the past, this used to be a true statement, but now the new research, it actually says they have increased placebo response, meaning that the less children available to, let's put it this way, in percentage wise, anytime you have a group that's closer to 100, you get a better result than comparing a group of 10 people only, right? The bigger the size, you get a better result. So children often have this placebo effect is increased, but this is information from old source, okay? So just be mindful of that. I don't mean to confuse you, but sometimes it's test questions that are been topics that have been there for years and years, and how we develop and change the way we do things. Sometimes they don't agree. This is one of them, okay? And I don't mean to confuse you, but I really mean to give you the right information, okay? So in the past, it's been known to come up questions where they say they have a reduced placebo rate. In reality, they actually have an increased placebo rate. So now you are in a pickle, and I know, and I'm sorry, but we got to give you possible answers for what you might see on a test and what's really reality. Okay? So anyone has a question, though? Sharon?
Yes, I do, Dr. Lopez.
Go ahead.
I think during my diagnosis test, I saw a question where they asked that a woman who has been on Lamictal, who has been
Okay.
on and she's trying to get pregnant. She's concerned about the safety. So I think the option was if she should continue the medication because Lamictal is safe during pregnancy. That was what I picked. But I think you didn't say anything about that when you're talking about
Okay,
Lamictal.
perfect. Yeah, great example. Thank you for that. So is Lamictal safety for pregnancy? No. Is Lamictal the safest for pregnancy compared to other mood stabilizer? Yes, right? So we always have to collaborate with the OB and adjust the risk benefit, meaning, hey, do you prefer her to be manic and depressed versus the possibility of a fetal defect? Which one is greatest and what is this possibility? So Lamictal has been shown to have the least interference with the fetus and the most beneficial for women who are pregnant. So yes, so you would collaborate with OB and you likely would still prescribe because it is the risks, the benefit outweighs the risk. Does it? Do you understand that portion? Okay.
I think I came through that question. The question was a list of medications to choose from. And I
Then you
think
go.
Lamictal was the question, was the answer.
Yes, because it's the safest of the mood stabilizer. Okay. All right. So when you have assessment for someone with depression, you want to assess for occurring conditions, and one of them is alcoholism. Okay, so always assess: are you drinking? Is your drinking causing you to be depressed, or is your depression that's causing you to be drinking? Okay, so always look for that. What else? All right, antidepressants, when and how to switch. You will surely get many questions here. If you have SSRI, SNRI, not TCS, TCA, and MAOI, any of those, you can go back and forth. You wait 2 weeks, so meaning for the test, you have someone on Zoloft, and you want to put on an amitriptyline. How long do you wait? 2 weeks. If you have someone on amitriptyline and you want to put on Prozac, how long do you wait?
2 weeks.
2 weeks. Okay. If you have someone on Prozac and you want to put on amitriptyline, how long do you wait?
5 to 6
6 weeks. 6 weeks.
So the exception is the Prozac. Okay. If they are on any medication to Prozac, 2 weeks. If they are on Prozac to any medication, 5 to 6 weeks. Very, very important. Why just 2 weeks? Because you want to degenerate the molecules. You want the washout period, not regenerate, degenerate. It takes 2 weeks, and then you start the other medication. Prozac has a longer half-life, which means it could also cause symptoms, side effects, such as insomnia. So if your patient is doing well, but now has insomnia, but doing well, no longer with depression or anxiety, what do? You recommend taking the medication in the morning. I cannot tell you how many times I'm able to fix the problem with just the timing of the medication. You do not need to prescribe insomnia medication, right? So think of it, the least amount of medication that can do the most good. So if the symptom is insomnia, take the medication during the day, drink less coffee, so forth and on. So the washout period for all meds, or roughly all meds, are 5 to 6 half-life. Okay. The triptans are given for migraine by the neurologists. They do that a lot, right? And when you have a medication with triptan and another one was serotonin, you could be at risk for serotonin syndrome. So you want to collaborate and switch to a NDRI, which is known as which medication?
Wellbutrin.
Wellbutrin. Why? Because it doesn't have a serotonin. Okay. So let's talk about, let's see what's next. Okay. 1 second here. Okay. I want to talk about timing again, because this is very important and you will see this on your test. Timing of the medication. Let's say you have someone comes to you, PHQ-9 is 14. You started the patient Zoloft, 50 milligrams. Come back in 4 weeks. PHQ-9 is 4. So initially it was 14. 4 weeks later is 4. Which of the following actions will you do? Increase the medication, reduce the medication, switch your antipsychotics, your antidepressant, or makes no change?
No change.
No change.
But PHQ-9 is 4.
That means it's working.
It's working. Do not screw anything in life that's working, guys. If it's working, do not mess with it. Everybody clear on that? Because this is a tricky question, right? A lot of people will say, let's decrease the dose. Do not mess with anything that's working. 2 principles here. One is, if it's working, don't break it. Second principle is, it takes 8 weeks for medication to work, 6 to 8 weeks. So do not make no change for the antipsychotics until 6 weeks at minimum. All right, so the same thing. Now, PHQ-9 was 10, and you started 50 milligrams of Zoloft, come back in 4 weeks, PHQ-9 is 19. What do you do?
Increase the dosage.
Increase.
Okay, so it was 4 weeks.
I
And
make
the
no
patient came
change.
back.
Because I would
Make no
No
change.
change.
No change. Okay.
Right.
No change. So, okay. Now the same scenario. PHQ-9 was 14. Now PHQ-9 4 weeks later is 23. What do you do?
Assess for suicide.
Assess for suicidality. Is the only thing you do. Right?
Wait, say those numbers again.
Okay. PHQ-9 was 14.
Mm-hmm.
You start on Zoloft. Now PHQ-9 is 23. What is your priority action?
Okay.
Decrease the medication, increase the medication, switch the medication, assess for suicidality.
Suicidality.
Suicidality. Okay. So now let's back to PHQ-9 or scales. If your PHQ-9 is minimal, let's call it a 0 to, let's call it not 0 because that would be too little, right? Let's call it a 5 to 9. What is your action in terms of antipsychotics and
No medicine.
No
Therapy.
medicine. What can you offer?
Therapy.
Therapy.
CBT.
Therapy. If your PHQ-9 is anywhere between, let's call it the 10 to, I don't know, 20, let's call it 20, 21, doesn't matter. What are your options?
Therapy and medication.
Therapy.
And
Now, your PHQ-9 is high, super high, 22, 23. Your only action is not to start, your action is not to start medication. Your action is only one, assess for suicidality. Okay? All right, so we went over when to switch medications, how long does it take? This is very important. You will see tons of questions on this, okay? Switching between one to another and the timing. Remember, 6 weeks, okay? 6 weeks minimum before you make no change. All right, what is your question, please?
So if it is like on a severe range, like 20 to 27, so we don't give any medication or therapy, just watch for the suicidality?
No, it's not that you watch for. Your priority, your first action
Oh, okay.
is assess for
Okay,
suicidality. It's not
got
to
it.
start on medication, okay? Yeah, but
Okay,
great
okay.
question for clarifying.
Yeah, thank you.
Now, why do you prescribe, which one is better, SSRIs or TCAs for depression? Like if you want to just cure depression, you're only looking at this perimeter of making depression go away and never come back. Which one is better, TCA or SSRIs?
SSRI.
SSRIs. Safer.
TCA.
All right, TCA, right? TCA. But is that a reality? We don't look at just one parameter, right? We're looking overall. And when we look overall, what is the advantage and why SSRIs are most prescribed?
Less lethality.
Safest,
Complicated.
safest for overdose and non-compliance.
So the reason why SSRI is prescribed is not that necessarily is better, which is not true. It's not better, but it does carry a lot less side effects. And the test is the risk of overdose with a TCA is a lot higher than, mortality rate than a SSRI. In fact, yesterday I was with a psychiatrist, and then she was like talking about that too, because one of her patients is several times overdose, and they was like, well, make sure that she's in a Zoloft, right? Now, let's say you have a cancer patient and on a lot of medication. Which medication, if you had the choice, would you choose for that patient? And the patient has major depressive disorder. Lexapro, right? Lexapro is known to have the fewer of few drug-to-drug interaction. Let's say your patient has anxiety, well, let's say depression and back pain. Which medication would be a good choice?
Cymbalta.
Cymbalta, Denvoflaxine or duloxetine. These are good choices. SNRIs. TCA, good for pains too, right? Especially migraine, the triptans. Now, alpha-2 delta ligand, that's your gabapentin and pregabalin, good for pain as well, right? So you got to match, is your patient with anxiety and pain and insomnia? Maybe a gabapentin would be great. Is your patient with fibromyalgia and depression? Then SNRI would be a great choice. What is the number one side effect that males are most concerned with antidepressant?
Sexual side
Sexual
effects.
dysfunction.
Sexual dysfunction. So if you encounter someone with sexual dysfunction and they say, hey, I love the medication, but I don't love what is doing to me, what are your options? Or some of your options?
Wellbutrin.
Wellbutrin. Give me another one.
Remeron.
Well, yeah, but we want to do that, right? We don't want to start them on some testosterone, but I see where you come from. But no, we can do mirtazapine, we can do Buspar, but high yield bupropion. So it's also high yield if you are matching your symptoms with the medication. And bupropion would be given to those with low energy. So if you are going to prescribe bupropion, what do you need to know before you prescribe bupropion?
I think
History of
seizures
hypertension.
or eating
Yeah, eating disorder, seizure, TBA, right? TBI,
Mhm.
sorry. Okay.
TBI.
SSRIs can cause increase in agitation in which population?
Adults.
Older adults.
Elderly.
So
Elderly
they could have a
population.
paradoxal effect, right? What other medication that could have a paradoxal effect in
Benzos.
general?
Benzo.
Benzos.
Benzos and also trazodone. Okay. All right. So again, it's not really antidepressants, but all medications. Here I'm giving an example of antidepressants. If you are going to give a PPI, omeprazole, pantoprazole, you need to wait 2 hours before you give you psychotropic meds. You can take the psychotropic meds first, wait 2 hours, PPI first, wait 2 hours, psychotropic meds. Do not put them together. It will affect its bioavailability and affect the patient. So again, paradoxal effect. Benzo can cause a paradoxal effect, which means rather than calming the patient, it might agitate. That's an important point. Avoid prescribing that medication in the future and never give benzos with Kava. Now, if you are concerned about your QT prolongation, right? One SSRI that you need to be concerned of would be citalopram,
Citalopram. Yeah.
right? So you do not want to give it more than 40 milligrams. And definitely you want to be careful if they're older adults, right? Over 20 milligrams. Now, clomipramine has a risk for serotonin syndrome, right? Higher risk, right? It's a potent medication. All right, I know it's a lot, okay? So now we talked about if asked which of the following medications which of the following conditions would have the highest risk for suicidality? Schizophrenia, right? But it is not only schizophrenia, is the question is asking you for which has the highest risk, right? So the highest risk is schizophrenia, but others, bipolar, depression, anxiety, alcohol use, eating disorder, they're all on your radar for possible suicidality. Homicidal ideation, then we want to look at your antisocial personality. When it comes to personalities in general, what age, how do you differentiate antisocial versus, let's say,
Conduct.
conduct? Okay, how do you differentiate antisocial versus conduct?
If it is
It's
above
about
age.
the age.
Age, right? So
Yes.
age is important. Age is important. When you answering a question about personality, ask yourself, is the patient older than 18 years old or not? If it's not, most likely is not a personality disorder. Be careful. Okay, age is important. Now, schizophrenia. You got to know what's the positives and the negative symptoms that that we see and why we give first generation or second generation. All right. So positive symptoms, in summary, is anything that's added to the normal. Yeah, behaviors that we should not have, like hallucinations, tasting, smelling, hearing things, right? Delusions. You need to know what's the true definition of delusion. Is having strong beliefs that are not based on reality, like thinking you are being persecuted or someone else is in love with you, right? That can be a delusion or paranoia. You need to know what thought disorders are unusual or dysfunctional way of thinking. Movement disorder, agitated body movement, right? But delusions are firm false beliefs that are not based on reality. Okay? So negative symptoms is anything that you should not represent a lose or decrease in the ability to initiate your plan, speak, express emotion or pleasure. You should not have, but you actually have it. So it decreases your ability to sustain planned activity, speech, maybe brief or more content, a lack of pleasure or interest, showing little emotions through facial expressions or voice intonation. Okay, so you need to know age for schizophrenia. And the first one is 18 to 25. Second one is 25 to 35. Why do I care? Well, let's say you get a call, you're on call, and your hospital call and says, hey, I need you to come over here and assess for this 45 years old. Family says this is the first breakthrough of schizophrenia. You go like, huh? All right. So go ahead before I get there. Go ahead and run it. Did you run a drug test yet? No. Okay, so let's go ahead and run one. And if it comes back as negative, let's go ahead and put this patient on a CT scan or MRI. In fact, I did that yesterday, by the way. No, not yesterday, last week. I'll talk about it in a second. So why? Because the breakthrough of schizophrenia, males, is 18 to 25. You need to memorize this. Females, 25 to 35. So it's easy, right? So where males stop, female begins, 25 to 35. It is important that you know the age. So I had a patient that came in last week, and the therapist is like, hey, Dr. Lopez, can you come over here and assess this patient? It just doesn't seem okay. So I go there and I ask, what is your name? And he goes, Mario. And then I was like, okay, shut the lights. Let me look at his pupils. His pupils constrict to light. So it wasn't nothing neurological right away. And then guess what? I did a MMSE. And his score was 20. You know, I was like, oh, great. Then I did a little bit more neurological testings, you know, hand movement, walking. He was slow to speak. So, but this is a 29 years old male. He should not be this slow. So my first thinking, you know, I got to put my orders of priority is this: he's on drugs, right? It looks like stone, but he can't. Well, he can, but it's unlikely that he's stoned due to his profession, right? So I send him to the ED, and this is 3 o'clock, and the ED calls me 11 o'clock and says, hey, he's not a threat to himself, but it's questionable if he can take care of himself, right? He's very slow to move. He's very slow to respond. His ability to cook and care for himself is questionable. And I said, okay, go ahead and run a MRI on his brain. Oh, you want to run an MRI? I said, yes. Why? Well, one is the age. He's 29, right? So it could be a prodromal symptoms of schizophrenia. It could. It could also be some type of early dementia, very rare. But guess what? When they put him in MRI, his ventricles were enlarged. So it kind of gives me confidence, and his blood test and drug was all negative. So it gives me confidence that this is probably a breakthrough first symptoms of this negative allogia, negative facial movement, decreased increase of negative symptoms, they're likely a prodrome of schizophrenia. So I did a little bit history, has history of schizophrenia in the family. Since I couldn't find anything else, this is the diagnosis for now, right? So when you put someone on an MRI and everything in the image should be decreased. But one thing that you might see increase is the ventricle. The ventricles are enlarged. Doesn't mean that it will always be that way, but if it's a clinical finding, you might see that. Okay. And he also had a decreased perfusion of the ventricles. Okay. So schizophrenia patients may exhibit changes or deficit in the frontal cortex. So his ability to do dates, planning was impaired. The amygdala, basal ganglia, hippocampus, and limbic system, they all may exhibit deficit, so lower ability in those functions. This can lead to aggression, impulsivity, problems with abstract thinking. So anytime you hear schizophrenia, you think abstract thinking. What is that? What does it mean to one that lives in a glass house should not throw a stone? That is abstract thinking, your ability to give a rationale for a abstract thought. So the lack of abstract thinking is a hallmark of schizophrenia. All right, age is important. MRI finds enlarged ventricles. Abstract thinking is important for schizophrenia. Okay. So what you do not want to do is give more dopamine, right? Because the problem is the increase of dopamine. Why would you give more dopamine to begin with? So that means you should not give stimulants, Adderall, Ritalin, right? And they may have low tolerability for alpha-2 adrenergic receptors like clonidine or guanfacine. They just may be less effective to those populations. But what you do not do is give a stimulant. You don't want to increase the dopamine, right? Guanfacine, clonidine, these medications may not fully benefit in this population. So if you're impatient and you want to send them home, you better set up ACT, assertive community treatment. Those benefit with low medication compliance, and they have this fantastic program that's open for 24 hours. They have a nurse, psychotherapy, physical therapy, the doctor, all in 24 hours. Why? Because the goal of assertive community therapy is to keep patients out of the hospital, working in the community. Okay? Who do you send patients? Who would be a good candidate for assertive community therapy? Those with medication compliance risk, bipolar patients, schizophrenia patients. Okay? Schizophrenia patients with high risks of medication relapse. Review the medication history and consider change from oral Haldol to intramuscular Haldol depot, right? So if they have problems with taking the pills every day, you may want an intramuscular depot. And the question is, how do you do that? Okay. So let's say the initial dose for the first month of 20 milligrams multiplied by the daily dose, right? So let's give an example. Make it, oops, sorry. Let's give an example here. Okay, Let's say that the dose is 10 milligrams BID. Okay. So your total dose is going to be 20. And then you multiply 20 times 20 would be 400. But you would give only a maximum dose of 100 milligram, and you ask the patient to return next time to get the remaining dose. So what you need to know is that you get your total dose for the day. Let's say if the dose was TID, BID. So you get the total dose of the day multiplied by 20, but the maximum dose you would give is 100 per injection. And the remaining, it can be given a few weeks later. Guys, if we're mentioned here, it's because it's high yield. Okay, so every line in the crash course content is super high yield. There is nothing here that's fluff. Again, what's delusion is a firm belief despite of evidence to the contrary. Go ahead, please ask your question. If you have a question, ask that. Okay, Melissa, go ahead, unmute yourself.
Hi, I put a little message in the chat. I had a patient that in clinical where he had a sudden kind of onset of catatonia. He lived with his mother. He was in his mid-20s. He had a sudden refusal to eat his mother's cooking. He was found at work, just catatonic in the middle of his workplace and had to be escorted out. He was hospitalized, but the only thing he was ever diagnosed with was catatonia. But I'm sure it was something more. The only thing that helped him was, well, the only thing that they really ever tried was lorazepam. It was given at 1 milligram QID. And even at that, he was still pretty rigid and flat, but he would talk. But the very first visit, he wouldn't even talk. His parents did the talking, but he did have auditory and visual hallucinations, and he would like go in the corner of the house and talk to himself. But I think it was schizophrenia, and
yeah,
I did share that. Yeah.
And
So,
they did the right thing. So you do a benzo challenge, right? I like I did that to my other patient too because he was catatonic. He was just slow moving. I did a benzo challenge with him as well. So that's what you do for catatonic patient. That's actually a very good clinical scenario. Okay.
I'm sorry.
All right.
What's the name of that challenge that you do? What did you call that?
You can do a benzo challenge. Ativan. You can do Ativan. You can do, Ativan is a good one. So for patients that are catatonic, you can do a challenge with Ativan and see if it kind of improves. Okay.
So you give them a dose of Ativan.
Yeah, give them a dose of Ativan and it should break through the catatonia.
Oh, I had never heard of that.
Yep.
Okay, thank you.
So if you have somebody with, let's say you have somebody with dystonia, what kind of challenge would you do?
Would you give
somebody,
them
Benztropine.
Benztropine.
Okay. All right. All right.
Benztropine.
So,
Benadryl.
Benadryl, right? So you want anticholinergic. So somebody comes to the ER, they just had an increase in antipsychotics, they can't talk, they're like, okay, I got it, no problem. Give them 50 milligrams of Benadryl, and then you can do 25, and then you wait 10 minutes, give another 25, you wait 10 minutes, give another 25. And they were like, oh man, this was hard. I'm like, so tell me what happened. Well, last week my doctor increased my medication, and I don't know, I just couldn't talk anymore. I said, oh, okay, got it. All right. So you got to know what delusion is, okay? Got to know what delusion is in detail. What's delusion is a false firm belief I mean, is a false belief, a firm false belief, contrary to the evidence. For example, my belief that their family is part of a cult. That is a delusion, right? So distinction between delusion and paranoia, right? Delusion is very different than from paranoia. Paranoia feels people feel that people are out to get them. Delusion, they just delusional about whatever, but they can kind of almost the same depending on what the scenario is asked. So how do you assess? How do you do a MSc on a adult, right? You ask questions. How do you do an MSc in preschoolers? You watch and listen. You watch and listen for cues, right? You're not going to ask them to, give me abstract thinking. You're not going to ask them who's the president of the United States. It's a preschooler. They may not know, right? Not going to ask what's the name of this hospital, right? So you watch and listen for cues. This is how you do an MSc for preschoolers. So I cannot tell you how many questions you will get on thought process and thought content. So if you don't know thought process and thought content, should really know. Okay. Thought process is assess the organization of the patient's thoughts and ideas. This does not refer to speech. Example, how are your thoughts? Logical, coherent, goal-oriented, or they are abnormal, asocial. Now, when you say thought process, we usually need to know tangential and circumferential. Can someone give me a difference between both of them?
Tangential, they go off and they never come back to the answer. And circumstantial, they go in circles. The tangential, they do answer, but they also give irrelevant information. And circumstantial, they never do actually answer the question and they go in circles with irrelevant
Okay.
information.
All right, perfect. I like that answer. So tangential, it will never give you the answer. Circumferential, it goes around and around, they give you the answer. And that is thought process. Do not put that in thought content. You need to know what does it go on your assessment. Thought process. What goes in thought content is suicidality, homicidality, visual hallucination, auditory hallucination. That is thought content. Thought content are the thoughts and perceptual disturbance. This information should be documented in the MSE or in the thought content portion of your assessment. I can almost guarantee you that examples of where would you document suicidal ideations, homicidal ideation would go. So the answer would be MSE or thought content. Okay, so no thought content. If they ask where would you document tangentiality or circumferential thinking, that would be thought process. So that's easy question, but you just got to take the time to memorize it. Okay. Has anybody got a question there or no? Okay. We're almost done for the night. So here is the mini mental status examination. First of all, you got to ask, what is the other name for this? Would be the Faustin scale. Faustin scales is also called the mini mental status examination. So second thing you got to ask is, why do I care? What do I use this for? Well, you use this to quantify cognitive status in adults thinking. Remember how my patient had the low thinking? His cognitive was pretty low, right? So you use this because it kind of assess for dimension like conditions with low cognitive. You want to quantify. Go ahead, ask your question. Mavis?
So I hear a lot about the MSC and the other test for dementia, but do you know if they mention the MOCA on the
Yeah.
exam?
Yeah, the MOCA can be another test for that used for dementia, and so is also the SLAM. Yes, they are there.
So would that show up on the exam, the MOCA? Because I don't hear too much, about
Probably
Oh.
mini cog as well. I mean, I think the MOCA is just fair to say that it's a test for cognitive uh, quantification, for example, but nothing too specific about the MOCA.
Okay, that's what I was wondering, if we had to know the
Yes.
scores or anything.
No, not the score.
Okay.
So one thing about the MSE is that high score is good, right? So in all scales, almost all scales, high score is bad. QH, PHQ-9, 23, ooh, horrible, assessed for suicidality. When it comes to the MMSE, high score is good. And so is the SLUM test, right? SLUM test, which is high score is good, meaning that they don't have dementia. So that being said, high score is good. Now, questions that we often ask is, how do you test which part of the MMSE is being tested when you do a series of 7? The answer will be concentration, attention, and calculation. What are you assessing when you are asking the date, season of the year, location? So you're asking for your orientation. Here is where a lot of people get it wrong. So registration, right? Assess your ability to learn new material within 1 minute, right? And recall it. For instance, name 3 objects and asking the individual to repeat them within 1 minute. How is that different than recall? Well, recall is asking for the same objects after 5 minutes. So registration, are you able to register the name of the objects and remember them within 1 minute? Registration. Recall is after 5 minutes. I posted the same question for years on Facebook, and every single time we get at least 50% of the people getting this wrong. Recall and registration. Every single time. Memory. I mean, fund of knowledge is who's the president, or who's the governor, what is the capital of your state. So, clock drawing test. You also do a clock drawing test in the MMSE. What other cognitive testing is the clock drawing test could be part of? Anybody?
To screen for dementia.
Yeah, but what other tests? Because we asked them to draw the clock in the MMSE.
It's
What
part
other,
of the slums.
okay, but
Mini-
also the mini
stroke.
mini cog. Yeah.
Genesis.
Attention.
Okay.
Isn't it a
So
part of
is
it's
the
part
mini
of
cog.
Mini cog. Yeah, mini
Mini
yeah, the
cog.
mini cog.
Okay. So the clock drawing test, MMSE and mini cog. So when you assess the clock drawing test, you're looking for problems, neurological problems in dementia, right? Why do you do it? Because it's quick and easy, 2 minutes. And if you find an issue, that would be where? In the right parietal or right hemispheres. Oh, can you call them either right parietal or right hemispheres? Yes. Right parietal or the right hemispheres. Is that the same thing? Yes. So when you have a problem in your right parietal and your right hemisphere, you have a constructional aprasia, which is inability to build things, stack things up, or draw objects, right? It is a damage to the right parietal or right hemisphere. Do not forget this, guys. Anything that I talk about is important. I promise you. For example, if you had a stroke or Alzheimer's, you could have a damage to your right parietal and you could not do a clock or constructional aprasia. Patient is unable to do a clock draw correctly, then the problem is the parietal lobe, right parietal lobe. Remember, nothing here is filler. Every line in the crash course review is important. Dopamine pathway, right? When I think of the dopamine pathway, I draw a quadrant. And my first quadrant, we'll talk about that in a second. But before we do that, let's talk about typicals and atypicals antipsychotics. So atypical, it has something special. It's atypical. And that is your 5-HT2A, which is also known as serotonin antagonistic. It is the hallmark of the second generation. Do you remember when I said that the first generation, the dopamine is blockade at 80%? The second generation, they added serotonin that will counterbalance the dopamine. So for that reason, now the dopamine is only at 60%. But the serotonin will kind of add a little bit of fat into it, right? So they act as both dopamine and serotonin antagonistic. Remember, antipsychotics can also be called as dopamine antagonistics, right? So on the atypical or second generation, now you have a little bit of serotonin. What type? Antagonistic serotonin, right? So because of that, they decrease the blockade of dopamine, therefore less EPS symptoms, but more metabolic syndrome symptoms compared to the first generation. So initial psychiatric, for the initial psychotic breaks, usually you want to treat with the atypical medication. And options for intramuscular atypical includes Invega, Geodon, and Abilify. Remember, once again, if we cover on my crash course review, every line is important. So you should know what are the atypical intramuscular medication. Invega, Geodon, and Abilify. Oh, there's more. Yeah, there is more. Most common, okay? Know that. Know every line in the entire crash course review. Otherwise, you'll be missing points. Dopamine pathways, break it down in 4. The problem is with schizophrenia is too much dopamine. Okay, where? Well, too much dopamine in a mesolimbic pathway. So remember, when it's talking about the pathway, dopamine is not talking about what's happening with acetylcholine. It's not talking about what's happening with serotonin. It's not talking about what's happening with prolactin. Because you could justify by saying, hey, you have a decrease in decrease in dopamine and increase in acetylcholine, and this is why you have X, Y, and Z. No, it's asking the dopamine pathway. So the answer is a dopaminergic answer. So here, the dopaminergic answer is in a mesolimbic, you have too much of it. So you have an increase of dopamine. In a mesocortical, you have a decrease in dopamine. And that is the cause for negative symptoms and depressive symptoms. You could also talk about serotonin, but remember, this is a dopamine pathway. The answer will be a dopaminergic. So mesocortical, decreasing dopamine. How about nigrostriatal? That's all about the movement. So here we have a blockade in the dopamine. When you have less dopamine, acetylcholine is going to shoot to the roof. But the problem is the low blockade of dopamine. And because you have a blockade of dopamine, you have an elevated acetylcholine, which leads to salivation, tearing eyes. So your acetylcholine is too much. Now you're salivating all over, tearing eyes, and diarrhea. So extrapyramidal side effects is because of dopamine blockade. And when you have a dopamine blockade, you have a symptoms such as acute dystonia. Remember? The muscles, mouth of the neck, spasm. And they can lead also to parkinsonia, akathisia, or akinesia too, right? And can lead to antipsychotics, other non-antipsychotics medications could also cause EPS. What are they? You need to know. Reglan. So does it mean somebody taking Reglan and antipsychotics, they're a double risk? You bet. So you need to know that Reglan could cause EPS. You need to know that. Okay? And tardive dyskinesia or dystonia, right, are also symptoms of the nigrostriatal pathway, the EPS symptoms. Okay? So because of the blockade of a dopamine and elevated acetylcholine, you have EPS symptoms. So one is low and another one is high, right? So individuals taking both antipsychotic medication and Reglan are particularly at risk. How do you treat EPS? Well, acute dystonia, parkinsonia, akathisia, you can use benzotropine or cogentin, which is anticholinergic, right? So anticholinergic. So acute dystonia, parkinsonia, akathisia. 3. For TD, do not use cogentin. If you do cogentin for TD, it will make it worse. So managing TD may involve reducing the dose or switching to a preferably atypical antipsychotics. All right. What is the question that you have?
So what's exactly the mechanism behind, cogentin making TD worse?
Because, okay. Cogentin making TD worse is because here is a long-term blockade of the dopaminergic, and cogentin, it doesn't help here for this specific scenario. Okay, it doesn't help. Here, if you see what is acetylcholine is elevated, and cogentin, what is it? Is an anticholinergic. So if the problem is acetylcholine too high, now you're bringing the acetylcholine down with the anticholinergic. The problem with TD is this is a long term. TD doesn't happen today. So this is chronic. So it's no longer effective for cogentin. There's no more, you can't just reverse something that's been done. So like a tattoo and try to take it out. Done. Right?
Meaning there are
what do you
structural changes, right?
say it again?
Meaning there are structural changes in the brain.
Yeah, That too, but it's more, it has more to do with the chronic use of a dopaminergic medications, and that will cause permanent change in the dopamine pathway, in the nigrostriatal pathway. Okay, but what you need to do for the test is stop the medication or switch to another medication, right? Now, there are two medications that are used nowadays, but again, Austedo and what is the other medication? Ingrezza, right? Now, should you know them? Probably, but these are like newer meds. Remember, the test is gold standard, so they may or may not be there. So what you want to do is application of this question. Do you remember the TSH, right? I said you need to go very careful, very slow for each one of the answers and cross it. The same thing you need to do for the dopamine pathways. You need to go to each question, look for the complete answers. Those are connected by and, because oftentimes you see like a dopamine increase and a decrease in acetylcholine. If that's correct, then it is the right answer. So you need to go by A, B, C, and D and carefully look in each one of those. Okay, which side effects are seen in patients with EPS related to nigrostriatal dopamine blockade through antipsychotics? So we see dystonia, Parkinsonian, akathisia, and you want to treat with congentin, a anticholinergic medication. So additionally, increase in acetylcholine can cause salivation, teary eyes, and diarrhea. What is your questions? Wendy?
Yes, sir. On the akathisia, I had taken a sample test. I don't know if it was in your question bank or the one I had to do for school, but that propranolol was the drug of choice, the first
Yes.
line treatment for akathisia.
Yes.
Can you clarify
So,
that? Okay.
akathisia versus, what is akathisia?
Sense of restlessness, feel like you're just can't sit still.
Yeah, and what's akinesia?
Well, it looks like laziness. You don't
movement.
Yeah.
Okay, so akathisia, right? You could give the first choice propranolol. Akinesia, benzotropine. Okay, so yes, you're right. You can call it acute, but for the test, more precisely, you can put them all as in benzotropine. One that's not benzotropine is TD. But if the choices give for akathisia, restless, propranolol would work better. Thank you for that. That's probably important. Okay. Did I answer your question?
Yes, sir. Thank you.
Absolutely. So if in a nigrostriatal pathway, the problem was too little dopamine, too much acetylcholine leading to EPS, now the problem in the tubulopundibular pathway is dopamine blockade and too much of prolactin. If the prolactin is too high, then you have hyperprolactinemia. And there you will see as an increase in amenorrhea, galactorrhea, sexual dysfunction, and gynecomastia. Do you need to know that? Yes. Also, very, very high yield is that when you have a blockade of dopamine and you increase the prolactin, you are at risk for osteoporosis. What else would you be at risk for osteoporosis? If you do what?
Movement.
Okay.
Exercise.
If you don't exercise, right? Smoking, drinking, low calcium, but lack of weight bearing exercise could cause osteoporosis. Okay. So you need to know that tubulofundibular pathway, the increase of prolactin, you are at the highest risk for osteoporosis. And you need to know What else about osteoporosis? Like lack of a weight-bearing exercise, being very thin could cause osteoporosis. Smoking, drinking. Okay, these are important information. And that is it for today's event. I want to share with you guys a little bit about the course, but before we do that, is there any questions or anything else that wasn't answered, or you kind of like want to review or have a different perspective on it?
I'm seeing a different range for TSH
Where?
in Fitzgerald's review.
What do they say?
They're saying 0.4 to 4 is the normal TSH. No? Okay.
No.
So
I know the
have
purple
seen-
book.
I'm sorry.
Yeah, so
about the same thing. I'm sorry about the same thing. I've seen, because I tried to read. I read the whole book, the review from the ANCC.
Right.
The ranges are, I think it's 2 to 10. So I'm not sure if
Right,
on the
right.
exam is.
And that is incorrect. That's why I mentioned that is incorrect. Okay.
What about the range T4?
Yeah,
What's
yeah.
the
I'm
normal
sorry.
range for T4?
So T4, you can do a 0.4 to 2.4. Okay. But again, you don't need to know, guys. You guys are getting in the weeds here.
Okay.
You get in the weeds. I mean, you might want to know T4, but most of the time they'll tell you if it's elevated or not.
Yeah, but my question is this: since you're saying that the ANCC, but that's the book, so on the exam, would that be 0.5 to 5 or 2 to 10?
Yes, go with my information. I promise the book makes thousands of mistakes, as I make thousands of mistakes too. You know, it's impossible to write down 50 PDFs and not make a boo-boo every now and then. So they did make a boo-boo too. They put it, I think, 2 to 10 or something like that. And that is incorrect. Go with my information on that one, trust me.
Okay.
Guarantee you. Put $1,000 on it. I mean, they made and that's okay. I mean, they should be, you know, they have a team and many years and they shouldn't make those mistakes, but it happens. We're all humans. It just happens, right? Sometimes I may misspoke and that happens. So yeah, but go with the information for the TSH with what I'm providing, okay?
So tonight, my first night
yes.
on, and I just have a question. Like, I
Sure.
didn't get the email that you sent earlier about, or someone from the program sent about this crash course. It did not have the code that you need to log on. Is it the same code every week, or do you get a different code? How does this work? How do I get on?
So not sure exactly what you're asking. If you're asking for the free course, we have a free course.
No.
need
I mean, like for tonight, for this, what we're doing right now.
No, for what we're doing right now is just a special session to give you guys a taste of the entire course. So it's only one time. Come in and ask your questions beginning of the crash course review.
Okay.
So you don't need a code. There was just a link that was sent, and whoever could come is here, and who couldn't,
No, I
is
said
it out.
when I tried to hit the link, it asks for a code or something in order to log
Yeah, I don't know why I would ask for that, but
Okay.
Yeah, I think there was a problem signing in.
okay.
There was a problem
Yeah, but
signing. I had to go through WhatsApp, so I came 30 minutes.
yeah, no worries. But
it came.
yeah, it might have been because it was early logged in. I don't know, but we'll see. All right, so I just want to cover a little bit for the guys that are new.
I'm sorry, just one question, and this is
Sure.
strictly like the test related. So I was watching like one of those review videos on YouTube, And this one lady
Okay.
said that, you know, when you go into the test, they give you like a blank piece of paper.
Right.
That as soon as she would go in, she would like write down like, oh, you know, like
Right.
the neurotransmitters that are affected in each disorder.
Yeah.
Is that okay to do? Like, is that not
Yeah.
considered cheating?
No, it's not, because you didn't bring that with you, right? It's in your memory. So if you go on my YouTube channel and then you look for dumping sheet, I did a 50 minutes video of what I would put on my dumping sheet, right? It's not considered cheating, because cheating is when you bring information from outside. When you sit down, you have 18 minutes. You can draw on 18 minutes, you can count on your fingers, you can do whatever you want within the 18 minutes. Or you can write the information that's important to you on a piece of paper, as long as it's coming from you, right? And that's not cheating, or at least I don't consider cheating. I did on my test, like sit down, I put all my scales in there, I put all my acronyms in there, I put all the Erickson stuff in there that I need to know that's in a course, and then I just, when this question 175, I just look at it like, oh yeah, that's Erickson. This is this stage here. It makes things a lot easier, as long as it's coming from your memory, right?
Okay, and then at the end, like, we discard that paper or we give it back to whoever?
Doesn't matter. Yeah, you want to erase your stuff and give it back.
Okay, great. Thank you so much.
Dr. Lopez.
What are you talking about? I don't understand. What are you talking about?
So if you go on the YouTube channel, you will see, and you search for dumping sheet, NP exam coach dumping sheet. I made a video on, before your test, you could write down like 1 page or 2 pages of most important stuff. Like, for example, drop X GBS for your medications that are inhibitors or inducers. You could write the acronyms for those medications that cause depression. You could do the acronym for those that cause mania, right? Or you could do the acronym for those that are Erickson stage of development. So that way, when you get the question, you can just look at it and you don't have to think, and you can look at your paper and match the answer to the question, right? So that is very valuable. And I did a whole video, 50 minutes, only on what I would put on my dumping sheet. Okay. So yeah, on the test day, you get a blanking sheet and you can write it down whatever you want and use it. So if you go to YouTube, NP exam coach, dumping sheet, you find a video that I did for you. It doesn't mean that it is complete dumping sheet, but it's pretty much everything you need to know. So I give it to you, right? So somebody asked, how long is the course? Well, I don't care how long it is. Usually 6 months. If you need more time, I'll give you more time. Some people have done in 3 weeks. Some people have done in 6 months, and whatever works for you, because life happens, right? So I just want to say here, the entire course is self-paced. You don't even need to come to class. But if you do here, if you click it, and then you start your video, right? Your first video of module 1. Under the first video of each module, you have a PDF. You download your PDF, right? And now you don't have to read the books anymore. So now you have this handy dandy PDF that breaks down the information for you. It will save you time. And plus it will save you confusion, because again, it's trying to minimize the amount of stuff that you need to know and focus on what really need to know. And then we go on details on what you need to know. And I even highlight what you need to know, right? I even highlight what you need to know. And you do this for modules 1 completely. Once you finish module 1, now you do the question banks for the module 1. You go on a question bank and you do the question banks for module 1. Let me show you what else. So once you have done your first video, make sure you kind of click on these things here. They'll give you a little noise. You get little points. Later, I want to get those points and transform them into t-shirts for you guys and things like that. But I'm not there yet. So it gives you a little motivation to keep on going, okay? But it also tells me how much you have completed the course. You can join our community by clicking here, and then you go to a forum. Here on this forum, you can ask questions by the modules 1. You can ask questions and things like that. So that way you have a forum.
I can't see your screen.
Oh, you can't. I'm sorry. Oh,
What is that?
you can see it now?
No, it looks black.
I can see
It's only,
I can see
yeah, I
it.
think it's only for you though, because
I
mine is.
think you need to press the presentation. That's what I was doing earlier. I didn't see, but when I press the presentation, there is a place that says presentation. When you click on the presentation, you see everything.
Okay.
Yeah. So this is the forum where you can share your thoughts, your rationales, a different way of thinking. You know, we all could benefit from learning different acronyms, right? So now let's say that you finish the first module, first video of the first module. All you do is go to the next one. Now it's going to be the dopamine pathway, and the next one will show up. And then you keep doing it. The reason why we do this is micro learning, so that you have a small amount of information each time, so you're not overwhelmed with the 7 hours class. And then you click on it.
Hello there, and welcome to NP Exam Coach.
Then you watch your lecture. You have downloaded your PDF. You watch the video. Then you keep on going. What's next? Okay, so next is going to be pharmacodynamics. And then you press on pharmacodynamics, and here we are, pharmacodynamics.
Hello there, and welcome.
And then you keep on going, right? As soon as you finish module, what's next step? And then you keep on going. Next video, boom, done. You do this for the entire course from modules 1 through module 5. Module 6 is our crash course review, right? Which we started today. We'll finish it off presenting the crash course review entirely on the 23rd and 24th. It will be 2 days. So if you guys notice, this is a mega course. This is not just modules 1, crash course review, question bank. It encompasses everything, right? So here you have. But if you go to the crash course review, let me bring this up here, and you can take a look. So look at what's under the crash course review. Again, okay, 1 second. Okay, the crash course review. Look at the files that you have there to download, and basically, instead of putting you into an 8 hours class, you have all this that you can take as slow as you want. Learning. Here's your video. First video. There'll be 6 videos here, and you have everything you need to know to pass the PMHNP board certification. Right, from modules 1 through 5, plus this handy PDF that I completed like a few weeks ago. Let's take a look on this for a second. Let me open, and then I'm going to share to you a different way of looking at the same subject. See. Open here my PDF for this course. Give me a second. Basically, what I did is, instead of of asking questions or talking about it, I created questions for you so you can ask yourself. Look, there are maybe 300 questions here that is important for you to know. Can you guys see it?
Yes, I
Yeah,
can,
so
but do.
define culture syndrome in your own words. So that way you can recall the information. Define susto syndrome, define somatic syndrome, define attack the nervous. What is mal de ojo? What is empacho? What is molera caída? What is wing? And then all of this is already done for you. If you have a hot mic, please. All of this, okay, which two SSRIs are the safest in heart problems? Certainly escitalopram. Which two antipsychotics can cause most weight gain? Clozaril or Lamictal. Which two antipsychotics cause the most sleepiness? Seroquel, Clozaril. And then it goes on, which two antipsychotics cause the least weight gain? Ziprasidone, aripiprazole, and Latuda. Guys, these are super high yield content, and I broke it down in a different way so that you have a different way of seeing the same subject, right? So no wonder we do have a seriously high passing rate, like the highest. I'm breaking down things in different ways so that you can benefit from it. So as long as you do the work, you will pass. You will pass. Now, there is no course or helper that can take the test for you, right? You have to do the work. You have to email me. You have to talk to me and let me know where you feel stuck, if you feel stuck, and let me know where and how I can help you. But the content is there. It is in PDF. It is in video. It is in live content. As long as you want, we're here for you and help you pass the board with no problem whatsoever. It's not going to do miracle. If you don't study, can't pass. I'm not promising that you can just show up and do nothing and pass. I mean, that's hard, but go ahead.
Dr. Lopez, where do you go to find the last one you show us? The last, the one that you are asking questions?
Crash Course review. Under the first video of each module is the PDFs for the modules. Okay.
Mine doesn't have, all my modules doesn't have the PDF.
Okay, so share your screen with me.
Okay.
While she's doing that, when you add, let me know. Let's go with Nuria. You have a question there?
I have a question, Dr. Lopez. I wanted to
go ahead.
If we can retake the test for the diagnostic. Those of us that okay.
You can take it as many times as you want, but remember, only the first time it's considered your valid score, right? Because if you take it 3 times, you got 99, you'll be like, hey, I got 99 and I'm super good. I'm going to believe you are, but it may not be the truth, right? So it's the first time that's what it counts. Okay. All right. Nuria, you have a question?
Actually, good evening, Dr. Lopez.
Hello, good evening.
I did find with the last PDF where you have what you were just showing on your screen. I found it in the course.
Okay, perfect.
Thank
Excellent.
you.
My pleasure. Susan, unmute yourself if you do have a question.
Oh, I don't have a question. Thank you.
Okay. Your hands is up this way. Mavis, you have a question?
I do. I was just, I'm not able to see the screen at all. How you was explaining everything earlier. I didn't want to interrupt you. But
Okay.
is there, I don't know how to use this. Like tonight is the first night I used it. I don't know how to make sure I can see your screen. I don't know what's going on, but
Yeah,
I don't see that presentation button. I don't see it to push it.
Okay.
Yeah, I'm not sure either if I can help you. I can always try to show you again later today and see if I can help you.
Okay.
But yes, but keep that in mind, and then at the end, I'm going to try to share again and kind of show you again. Okay.
Okay.
All right, Stella, do you have a question?
Yes, doctor.
Hi.
Thank you for recognizing my hand. This is my first time. I just signed up,
Okay,
and
great. Thanks.
yeah, I'm graduating in August, so
Okay.
I want to be doing everything I can so that
Yes.
when I'm done, I take my exam as soon as possible. So
Yes.
I have not taken the diagnostic test, and I have not really opened any of the module. Do you? What is the advice? Take the diagnostic test before you can start opening the module.
Yes.
Oh, okay.
Yes,
Just take it.
because it will give you a feedback where you are now and how much you have to improve. Okay.
Okay. Okay. And
All right.
I'm not going to be as fast as maybe others because I have my
No,
schoolwork. I still have my
it
schoolwork
is
that I need to do. So,
Stella, you go as fast as your life allows you. There
okay.
is no rush. We're not charging you for the time. You can take a year if you want to. I'll be here next to you. We'll walk through it. Whatever comes up, whatever you can do it. If you can't, that's okay. Just do it when you can. All right.
Okay. Thank you.
Absolutely. Now, who's sharing the screen there?
It was that is me, Dr. Lopez. That is what
Okay.
my screen is showing.
Can you go up a little bit so I can take a look at it?
I can't do it. I've been trying to go up, but I cannot make it up.
Yeah, you have a little scroller there on the right-hand side on your presentation, not on Google, on your presentation.
Okay. Right.
Melissa, we still have another semester starting in September, but plan to join. Yeah, join today. I'll tell you though, join today if you can. This I'm providing you a discount for you guys that join today. This will not be available anymore. Okay. Here's the thing, guys. This comes down to $2.07 per day. So, I mean, think about how many years, how many hours, and recording and live and emails I spend on helping. This comes down to $2.07 per day per student. Okay, so it is super insane cheap, and I'm still giving like an incredible discount. So, other competitors, Fitzgerald, they'll charge $1,200 for this, and they will not even give as much. So, this is incredibly. This is not entirely about money, right? So there is a lot of personal gain that I have here, the satisfaction that I get in being with you guys. So that's why I don't really care a whole lot about the price. Okay, Kelishi.
Good evening, Dr. Lopez.
Good evening. Hi.
The question bank is more in depth. I'm wondering, do we need to study all that before taking the practice test?
No. For the practice test is one thing. For the question bank is another. Now, I'm intense. I would do the question bank at least twice before I would test it out, right? I mean, I want to walk in a test center knowing there is no possible way that I would get more than few questions wrong. I want to make sure that I would be not stressed at all. So, and you do that by really doing a lot of work, pre-work. Now, the question bank is not the diagnostic test. These are two different modules, and they cover two different things. Did I answer your question? Okay. Maybe. I think she's muted. Not sure.
Yes, you did.
Thank you. Thank you. Absolutely. The person that's sharing the screen, can you go on your presentation and not on Google Meet, and then share from your presentation? You kind of move the presentation up and down. No? Okay. Cooper, what are your question? Cooper? Oh,
One second,
Anna?
I'm so sorry. I'm
Okay.
just, hello.
Hello, go ahead.
Hi, doctor. I was just wondering, like, from where I can find that 350 question you made to ourselves, like, what medication that you were sharing
Okay, so let
before,
me,
like, few minutes. I'm in the
yeah,
course right now. Mm-hmm.
all right, let me go ahead. The course is in order, right? Let me
Yes.
just say, you go one video at a time, it only shows you one thing. So it prevents you from being overwhelmed. But let's say you want to get out of order and you want to go straight there. So let me share with you a few things that for all of you guys, that's very good things to know. Well, first thing you need to know, you can go to all trainings here. You see all trainings? Oh no, somebody else is sharing.
No.
Hold on. Let me share my screen. Okay. You guys see my screen?
Yes,
Yeah,
I
I
can
see that.
see it.
Yes.
Okay. If you go all trainings,
Uh-huh.
it will show you all the modules.
Okay.
Then you can go modules 1, 2, 3, 4, 5, and 6. Crash course review.
Uh-huh. Yeah, I see that. Mm-hmm.
Okay, 1 second. It's kind of showing up here. All right. Well, it's taking a little while.
Mm-hmm.
All right. So if you go on crash course review, module 6, and then under the first video of the crash course review, like under any first video of each module, you're going to find your PDFs right here.
Okay.
Now I got it.
You got it? So
Oh.
under the first video for each module, not every video. Okay. Now let me show you something super cool that nobody has it. All right. This is super cool. If you go here, you see this here on the right upper screen. It has this question mark. Okay. So what questions? Tell me about lithium. It's going to tell you about lithium because I recorded and they kind of memorize everything that I said. And now it's going to give you an answer. So it's like you having me next to you, even though I'm not there. So it's saying lithium is known for a mood stabilizer and used in certain mental health conditions, such as bipolar disorder, and it has a low therapeutic index. Didn't I say this today like many times? So it records what I say. You know, and then the toxicity when it reaches over 15, and so forth. Now I can say, tell me about borderline so I said tell. Okay, so it tells me about borderline personality disorder. So tell me about mania. And then it's going to tell you. Like, you have to go nowhere. Your research is done for you. So tell me about TSH levels. Okay, maybe it didn't this time. What are the values? So make a better question, right? Oh, I got stuck. Let's see. What are the values? TSH. Okay, so it's gonna give me TSH values. So Notice that it could sometimes make a little boo-boo like it did here, right? 0 to 50. So don't take it 100%. It's supposed to 0.5. It kind of give me a little bit different, but this is a very, very valuable resource. So where do you find it? You go here.
Got it.
Okay.
And
So
I have
use
one more
that.
question, sir.
Yeah, go ahead.
Go ahead. Sorry.
Go ahead, please.
So,
Ask the
like,
question.
when we are doing the question, right? Like they give the short form of like a assessment tool, just like if we are doing the autism assessment or depression, like MMSC. Like in the exam also they give the short form because it's so many, and I'm like getting all over. If there is no full sentence like autism, this tool is mini mental status examination or mock, you know what, like I'm getting so confused with like short form. I don't know, I mean, like,
I am having a hard time understanding your question, though. I'm sorry.
no,
Can
sometimes
you?
we are doing the assessment tool for the
Okay.
diagnosis test, right? Like
Mm-hmm.
for the depression we will do MMSC, slum, mock.
Mm-hmm.
So like
Yes.
on the like when I'm doing the question, right, on the like practice question, they have a like just short form like MMSC, mock,
Sure.
or like MAD as it like autism. So if there is no full like description, then I'm getting confused
Okay.
to answer that
So
question, you know.
yes. So they will not give you a description. Like if they said cars, they will not tell you what the cars scale
Yeah,
is. You need to
like
know what
audit, this is like audit, this is Siva, this is
they will
yeah.
not tell you that. They will not tell you, because if they did, then you would be able to figure out which scale it pertains to, whether it's a toddler, what it's preschooler. They will give
Oh
only the
wow.
acronym, so you need to know. You
Oh
need to
my
know.
God.
Very
Yeah,
important.
yeah. Yeah,
But you don't
that's
need
what
to
I
know
was
all
like
of them.
getting.
So I mean, only the ones that I mentioned in the course.
Oh, okay.
There's still a lot, but a lot less than what the book would mention. The book would mention 50, right? So I'll bring
Yeah.
it down to 10. So
Okay.
okay.
Yeah,
All
no
right.
problem. Yeah.
Yes.
Thank you so
So
much, doctor.
absolutely. Anybody testing very, very soon, if you're testing very, very soon, you can just, if you're not in yet, you can just do the crash course review. We have one that's already recorded and ready for you, or you can participate the ones that are live. Up to you, right? And get led. And what is your question? So we have the same format only for the crash course review if you feel like that would be best for you. Go ahead and ask your question.
Hello, good night.
Hi.
This is my first time. My
Well,
course
welcome.
is ending in August, like
Okay.
Stella.
Yeah.
So I'm going to buy the course to prepare for now
Yes.
to maybe in October or November.
Yeah.
I can take
Totally
my.
fine.
So the
Yeah.
the link that you share
Yeah,
in
in
the
the chat
message.
box.
Uh-huh.
If you go there, click the link and just scroll down, and then you enter the code and you get a nice discount.
Okay, and another question. After any module, can I see any question or test bank or something like that?
Yes. So you finish the modules, and then you will receive an email from you with a question bank. The question bank is located in a different website. So you have to log in a different website, and then you do module 1. You finish the videos on module 1, and then you do question bank 1. And you keep going back and forth between the videos and the questions, videos and questions.
Okay, but this included in the course.
Yep, everything is included. We included a mega deal. So it's enormous, the amount of resources that you have here. PDF, question bank, diagnostic test, modules 1 through 5, crash course review, WhatsApp group, student support, email, forum, everything you could ask for, in artificial intelligence, everything. We put everything possible. Only thing that's not included is a flashcard, which is Brainscape, is not my app, but it's a extra, but it's not anything that you need to pass the board, you have it.
Okay, thank you so much.
Absolutely. All right. Anybody else has questions about the course or where to find X, Y, and Z or anything that can be of assistance?
Yes,
Uh,
Doctor. Says Stella.
Hi, Stella.
I'm good. I watched one of the
Hello there.
videos on YouTube, and somebody did mention uploading the purple book. I could have not found it.
Okay, so if you go on module 1,
Yes.
under the first video of module 1,
Yes.
I also put a book there for you.
Oh, great. All right. Thank you.
Yeah, no problem. Okay. I'm gonna put the video for the dumping sheet. Let me see here for you. Guys. Okay, let me share this real quick. So you can go online and look for it. You can put NP exam coach dumping sheet, and then you can get this and then get a piece of paper and write it down. I mean, I break it down for you here very easily. Okay, so if you go here, it says, hopefully you can see, dumping sheet, the best PMHNP sheet. So hopefully you can see that. Just take a picture of that, and I went over 43 topics that you must know for your PMHNP and board certification. That is the dumping sheet. So, and that go in detail and kind of like get you prepped and ready. Okay. Yeah. So tons of resources. But you know, the difference between the YouTube and the course is huge, right? YouTube is just a taste. It's going to give you a lot of stuff. And I know people are like, oh, you give us so much. Yeah, it is a lot. But wait until you see the course. Wait until you see the course. It's going to blow your mind because it's a lot of content. It's a lot of information. It's a lot of support. It will save you tons of time. And it's really a very inexpensive price too. Okay. So guys, you won't regret purchase this review. It has everything you need. Thank you, Nuria. I appreciate that for sure. Very much for sure. Thank you. Absolutely. Yeah, no, on and on and on. Every single day we have people passing. Every single day. And the first thing they say, this has been the best investment I ever did in my career. Some people even said, hey, I have learned more in your course than I did in my entire nursing career. I mean, that's a big statement, right? That's a huge statement, but I hear that quite often. You know what I hear the most? Dr. Lopez, I heard your voice whilst testing. I'm like, wow. I mean, that means that they've been doing the course, they've been watching, and immediately when they read the questions on the test, they are able to recognize where connect to the course and being able to really get the right answer. I hear that all the time. I think somebody else last week came on live and said the same thing. So that means it's working really well for them. So
Dr.
yeah.
Lopez, have you had someone who failed the exam?
Yes, I have. Yes, I have people that failed the exam. And if that happens, very, very little, not very often, but it's because they do something that I don't recommend. For example, I had somebody in the beginning that I gave her the course, but she already had enrolled in somebody else's course, and she only did somebody else's course, and she failed the test. And then she's like, oh my God, I should have done yours. Yeah, you actually had the course and you had everything in your hand, but you preferred to pay and get somebody else and not pay attention to what we needed to say, right? And then she came back and she did only mine, and then she passed.
Okay.
Now or another example is people start deviating from the program. Oh, I just want to do the question bank, or I just want to do the diagnostic test. Well, this is a war. I mean, I take this as a war, and each one of you guys are, you know, it's your battle, and I'm here to help you. I would not walk in at that center with a slight doubt that I would pass. This is how I would take this, right? This is the most important test of your life. I would study this. I would love it. I would learn it. I would be on top of it, because that's what separates you from your great life. That's what you want to be, right? A little while ago, 2 years ago, you said it yourself, I want to be a psychiatric nurse practitioner. I can't wait to take my board exam. And now you are. So give it all you have, all in, make this an exciting transition from nurse to practitioner. So for sure. And do you have a question there? No? If no more questions, guys, you have the link, and you have a question? I'm not sure. Peter, do you have a question?
Yes, I do. Yeah.
Hi, Peter.
Hey, how are you?
Good. And yourself?
I'm good. So, what's the cost of the packaging?
Sorry. So, hey, Peter, if you actually, do you see the message chat there? The Google chat. Yes or no?
His mic is muted.
Your mic is muted, Peter, if you are talking.
No, I can't see the messages on the Google
Okay.
chat because I left and came back here.
Oh, okay. So let me put it there again. So if you go on the right-hand side of your screen, it should have like a lock, square, and next to that should be like a chat with everyone.
Yeah.
So if you go there and click on the first link, and then it's going to take you to the page for checkout. Let me actually share with you guys here. So I had this. Let me share with this. So I have this for 2 days set up for this discount. And since it's Mother's Day, and I'm offering this on this special occasion, once the discount, the days are done, I will never offer this cheap because it's not fair. You can go all the way down, apply your coupon, take 40, and then you get a nice discount there. Super, super nice discount. So it's that simple. And then once you enroll, you get something called a magic link, and you can start right away.
Okay, thank you.
Yeah, it's all self-paced, and obviously you can attend as many live classes as you want. You receive the links for the classes the day before or few days before. Hey, we're meeting this time. We have a calendar. On a daily basis, you can contact me via WhatsApp or email, and then we'll welcome you in, get you in, and get you studying and get you passing the board for sure.
Thank you.
Absolutely. Are you able to see the chat box where you can click the link?
Yes, I've seen the link with
yeah.
with,
So make sure
discount.
that make sure you
Check
guys
40.
use this. Yeah, because it will not be available again. It's a really good deal, I think. Any other questions from any? Go ahead, Peter.
Sorry. So is this a 30-day walk to success, or is it a 6
Yes.
months?
It is called the 30 days because you can finish in 30 days. I have seen people finish in 2 weeks because everything is there, right? Now, I have people that have been with us for a year. 6 months is where the course will shut off. But if you need more time, I always give more time. I don't charge. It's 6 months. You'll be okay. All right.
Thank you.
Thank you, Peter. Wendy, thank you. Peter, thank you. Appreciate that. And do you have a question? I'm not sure if Anne had the question.
I have
No
a
more
question.
questions.
I have a
Okay.
question, Dr. Lopez.
Go ahead,
Unfortunately,
Mavis.
my husband had a stroke Monday,
Oh, I'm sorry.
and I had signed up for the course, and I was interested in taking a course, but it's a lot right now going on. And like I said, I would really like to see this screen that you showed everybody else. Can I email you and see when we can set up a time where we can screen share or do a Zoom or something where I can understand how to work the course so I can, do these different modules and things and take these tests on my own time?
Yeah, please email me, Mavis. I'll definitely take care of you. Please, whatever is going on, let me know if you feel that that I can be helpful. Please email me. We can always meet together and try to. You're not able to see my screen right now, are you?
I can't see nothing. It's just black. I can't. When I first signed on, I could, but I don't know what happened.
So try to sign off and sign back in by refreshing your screen, because I think
I
it's
don't
only
even
you.
know how to do that.
Just go in a screen over there, and next to the screen on top where your website, click on it and click it back on, like you're refreshing your screen, and then you should be back. While she's doing that, Stephanie, what is your question?
I'm taking my boards May 20th. I feel like I have a pretty good handle on a lot of the information, and I'm wondering if you think that I can do this in 10 days.
Yes, you can. You can. I mean, what is your schedule like?
I've taken off of work for the majority of the time.
Yeah.
But it's pretty open, and I want to take the test before the kids get out of school.
Yeah. So you can do this. You can do one per day. So it'll give you up to 6, module 6. And then work with me. Let me know where you stuck points on a daily emails, anything that you feel that, oh, I'm stuck. And I'm going to send you some extra PDFs for you to focus on. Or you could start off on module 6, which is the crash course review, if you already have a good handle. Actually, I would do that. I would work backwards. I would take the diagnostic test, see where you at.
Yeah, I think
Then
that's what I'm gonna do.
Jump to crash course review, which is what we are doing today, but much more intense. And then after that, take another diagnostic test and then see where you at. Then go back to each module, download the PDF, and then see what you're strong on and what you're not, and then watch the videos, only the things that you're not strong at it. So that way it will save you time.
Okay, I already know where my weaknesses are, and it's on theorist and
So module 4 is one of the best modules. It will break down each of the theories by what you need to know. For example, if we say strategic family therapy, what are the 3 things you need to know? I'm not going to bore you with all that extra. So if you go to module 4, you will benefit. I think you'll benefit too also of module 5, which is laws in psychiatry, things like that.
Yes, that's one of my other weaknesses too.
So you could, I mean, that alone, it could increase your points by 40, 50 points, because there's a lot of questions on therapy, a lot of questions on law. I think you would benefit from it. So
okay, sounds good. I'm going to purchase the course right now and
yeah, and get my email. So I really hope that you email me today, because I want to send you a special document, so that will be beneficial to you. That's not in a course, but it's kind of summarize everything for you, and that way you kind of PMHNP at npexamcoach.com, so that way you can at minimum cover the most high yield in writing. So
yeah, okay, PMHNP
npexamcoach.com.
Dr. Lopez.
What?
Oh,
com?
PMHNP at npexamcoach.com.
Okay, sounds good. All right, thank you so much.
Thank you, Stephanie, for joining our course. Really rooting for your success, for sure.
Okay, Dr. Lopez, I can see
Hello.
now.
Okay, you can see now, right? So yeah, great, awesome.
My question is now, since I can see, can you show me right quick? I did module 1, but like other people, I don't see how do I get to the questions that you
Okay,
need to ask for
so
my.
module 1. So you got to go in your email
I did
and
that.
do.
I completed
And
module 1.
so you completed module 1 of
But
this
I didn't
course,
do the
correct?
question. Yes, I didn't
Right.
do the
So
question.
the question is located in a different website. You
Oh,
have to
where's that?
go, yeah, you have to go on your email and
Mm-hmm.
search PMHNP question bank.
Oh, I saw that. I saw that email.
And then you follow the link and you follow the password and you gotta sign in. You already have been signed up by us, so you don't
Okay.
have to pay. Okay. If the website's gonna ask you to pay, only if you want to pay, they're gonna take your money, but you don't have to because they already granted you access. So you gotta sign in.
Okay.
And then
you
you do
gave me a password, or do I need to make up a password?
the system send you a password or you kind of change it on your own.
Okay. I think
Okay, so you do not buy it because you already bought you. You already got it for you. It's okay.
Okay.
So you have to
All
sign
right.
in order to use it.
All right.
Okay.
Thank you.
Absolutely. And
I really
remember,
appreciate it. Like other people, you are a true blessing because those videos, those YouTube videos are so helpful. And I
oh,
was
I'm
like, I
glad.
just have to sign up for this. And I appreciate you being so courteous and generous to everybody and helping everyone. There's not too many people out there like you who
Thank you.
not
Thank you.
trying to make so much money. And
Yeah, it's a bit selfish on my own because I love it. So it's like it's not only for you because I really like to teach and talk and be there for people. Did it like I said, few things that drives me, and one of them is it's community. Everyone has their own thing. I like teaching and I do enjoy what I do, so it's not really a work. But I know that everyone is different. And I'm glad that you guys are here, and I'm glad that the positive feedback for sure. Okay,
all right,
thank you for
thank
that.
you. You guys have a good night. Happy Mother's Day to all the
Happy
mothers.
Mother's Day to everyone.
All right.
You too.
All right. Do we have a question again, Stephanie or Anna? If not,
Yes, Professor.
go ahead.
Dr. Lopez, I already made the push, so I received the welcome email. In this email, I can find the user and the password for the test, the question.
So all you're gonna do is look for something called a magic link, and you click on the magic link, and that's it. And every time you go back, the course automatically knows where you stopped and know who you are, and they tracks you. What are you doing? So later you ask me how you're doing, I'm gonna track you, and then be like, okay, you spent this many hours, you did this X, Y, and Z, and I can give you a true, firm advice if I think you should test or not. I don't sugarcoat. I tell exactly what I think.
Okay.
So
Thank you.
absolutely. Look for the magic link and they will get you in. Stephanie, what is your question there?
I'm sorry, I didn't mean to press that.
Okay, no worries. Okay, guys, it has been a blessing night, and I'm very thankful for you guys to be here today. Does anyone have any questions? No? Okay, great. Testing soon, the
I have
next
a
week.
question, Dr.
Go
Lopez.
ahead,
Good
please.
evening. Yes,
Good
sir.
evening.
Please, is this recording going to be available for those people that can't join? I've been trying to join for a long time.
Yes, it will be available. But when you say you're trying to join for a long time, what do you mean by that?
I've been trying to join, but I don't have a good service in my house, so I just moved.
Okay.
Yeah.
Oh, I'm sorry. So we have an app, okay? You can do all this in our app. I don't like to talk about the app because I think study should be like a big screen and pen and paper. But for those that prefer to start on an app, we have an app. Okay. I don't like to talk about it, but it's there. If watching through your phone is what you guys prefer, that's okay. I think it's best on a computer. But if it helps, we have an app. Okay. Yes, we have this downloaded too. It'll be on the YouTube. If you like to go on the YouTube, mpexamcoach.com YouTube, we'll go ahead and make sure that's there. But you know, it's not because it's my course, but I really think that if you are in the fence, if you're like, oh, I don't know if this is a good deal or not, your guys may be missing out in an excellent deal. I mean, I'm biased, but I really think that the value that we provide here is unparalleled to anybody out there. So our students are blown away with the support and things that they get in this course. So it'll be the best money ever invested for sure. But if you can't, oh, there's one more thing. Okay. If you're going through financial difficulties and something is difficult in your life, let me know. Okay. So, like I said, this is not entirely about money. There is a portion of this that is about money, of course. I have to pay my employees. But at the end of the day, I really enjoy what I do. So if it's something that's like, oh, it's just money, let me know. Okay, email me. All right.
I like
Right.
to say
That being said,
I like to say thank you, Dr. Lopez. A friend of mine that was in the cohort before my semester, she took your program, and she came with some other students. Well, she told us about your program, and that she was telling us how right on your LMR and your program and your course were with the boards and everything, like the things that you were saying. She was kind of like telling us some things. It was right on course with what you've been saying through your through this, and so it's inspired me to join. So I just want to.
all right.
So.
Hey, Stacy, that's awesome. I'm glad to see that.
Yeah.
For the first 3 years, I really didn't do a Facebook. I didn't do anything. I just care about the students. And now I'm very thankful that people are doing that for me, because I wasn't concerned about growing the company. I was concerned about each one and everyone. So it's kind of like I left, yeah. So right now we're kind of expanding a little bit and helping others. But when people start talking about it, that's what really gets going. So I appreciate that a lot.
Okay. All right. Thank you. Thank you.
Absolutely. I think it was somebody else that asked to put this on again. I put on the link. Peter, you got the link? We were about to be off. So copy and paste the link on your browser. And if you have any problems or issues, email me at pmhnp@mpexamcoach.com.
Thank you. Got it. I keep
Okay.
dropping out.
All right.
Thank you.
Thank you. Anybody else has a question?
You, sir. My name is Dr. Love.
Thank you, doctor, and I will join you next week.
Okay. Yeah, well, next week. Well, here's the thing, guys. I am in South Korea right now. I am finishing my tour here. Next week is my move. And after that, we're going to do the mega crash course review, 2 days together. So no Kahoot tomorrow, no class next week. But you have the course. Your job is really to get as much as possible done. So when we meet the 23rd and 24th, you are on point with the rest of the course, or as much as possible.
Okay, thank you.
Thank you. Absolutely. So remember, 2 days. It's going to be 2 big days. We're going to do 2 big days of everything you need to know to pass the board, and it's going to be awesome. All right, everyone. Good night. Thank you for being here today. Take care.
Good night, Dr. Lopez.
Bye.
Thank you.
Good night. Thank you, guys.
Dr. Lopez.
Bye-bye.
Dr. Lopez, this is Gladys. You said to email you. Hello.